हुई क्या बारिश? आई था मैंने। क्या बोली?
Can everyone please mute themselves? And just a gentle reminder to all the finalists, could you just write down the name of your team in front of your names? That would be easy for us to assess the finalists. Thank you.
We are live on YouTube now. All the best.
So good evening, everyone, and welcome to the National Induction Session of the Membership Drive 2020. So to begin off with the introductions, I am Shravya, a final year medical student from WIMS, Bangalore, and I am the Zonal Officer Internal of South and also the State Head for Karnataka. We have here with us today Dr. Avi Singh, the VOC, the Vice Overall Chairperson, AMSA India, who is the right person to be leading this huge Interna family. Also, we have with us the three other zonal officers internal, Akriti Gandla, the Zoe of West Zone, and also the state head of Maharashtra, Mansimar Kaur, the state head of Punjab and the zonal officer for the North Zone, and Tanya Polik, the state head for West Bengal, also the zonal officer internal for the East Zone. I do welcome Dr. Avi Singh to share his few words before we start off this induction session.
Hi, Shravya, am I audible and visible?
Yes, Avi, you are.
Perfect. Okay, welcome everyone. It's such an ecstatic feeling to have all of you at the same time over here. Congratulations to all the finalists of the National Integrated Medical Quiz. But before you guys move ahead, I just want to congratulate everyone who's been here. And I think the right people to guide you about AMSA, Asian Medical Student Association, Chapter India, are all of them over here. We have zonal officers internal for all the 4 zones of India, South, East, North, West, who will most preciously and most amazingly guide you through what AMSA has to offer. I'm pretty sure a lot of you do know about it. A lot of you are more excited to know about it. What I'm just going to do over here is take a couple of minutes to very casually tell about why do we want to be a part of AMSA. Very, very basic few points. There are a lot of student organizations in the country, but I think AMSA stands very, very different because of the following points. We are very non-political. That does not mean that we do not work for students. I mean, we take stands where it matters. It is just not the public health part. It's just not the research part. It's not just the friendship part. It's everything in there. I mean, you think about it, and AMSA is more than willing to do something about it. And the best part about AMSA is that who is AMSA? It's not anyone else. It's not just us. It's every medical student who once becomes a member. So you are a member for a lifetime. And I am very proud and very positive to say this, that most ideas, events, and national competitions that have happened under AMSA have been just very little ignited thoughts from our own members, which have seen the light of day in such a big way. And with great pride, I say that I think until last year we were about 40 colleges big, and this year already we are in 30 states of India active, and more than 220 college heads already. So the reason that AMSA is growing is because we want everyone in India to benefit from what we are doing. Not if something is happening in Punjab, if something is happening in Delhi, why should Kerala be left behind? Why should Jharkhand be left behind? And one thing that I personally felt when I was in college was, we all have colleges which have their own restrictions. There can't be some national events. The authorities are hesitant. The people around us are not willing to participate. I think as AMSA, our vision is to transcend those borders. If you are one person in your own college who wants to do something, we have something for you. Your college does not matter if you want to be a part of a national thing, which ranges from MUNs to international exchanges, which Shravya, Kruti, Mansimar, Tanya will very beautifully tell you. I don't want to take your time over that. But one thing I think I'm very proud about, and I feel AMSA is very different because of, this year we have national houses at AMSA. So I am pretty sure I had this vision in my head when I used to watch Harry Potter. There's Hufflepuff, there's Gryffindor, and there's house points and everything. And doing that for a college is tough, and sometimes we don't need it. But we just had a vision. Why not do it for everyone in India? Why not make everyone feel a part of something bigger? And I'm very glad that we are successfully doing it, and we already have our 4 houses. The Zoes that you've been introduced to are themselves the de facto house captains of the four houses. So I'd like to officially introduce you guys, depending upon which state you're from. We have Shravya from Southern Sapphire Stormbirds, which are leading currently as with the House Cup, which will be declared at the end of the year. We have Akruti from the West, Western Medallion Valkyries, Mansimar from the North, Northern Crimson Thunder Jaws, and Tanya from East, Eastern Emerald Enfields. So, I mean, this is just one shade of what all AMSA has to offer. And we are more than willing to have you in our family. Don't join us for us, join us for yourself, because we want you to enjoy and benefit from each part, each shade of AMSA: action, knowledge, friendship. That we are going to do the same work. We want you to be a part of it. And our director of memberships and development, Love, has offered an amazing financial incentive, which Shravya, Kruti, Mansimar, Tanya will just guide you through. So officially, thank you everyone for joining. Thank you so much for giving me this opportunity, all these Ois. You are the most amazing people that I know. And in a way, guys, these 4 people represent every one of you. So thank you, Tanya, Shravya, Akruti, Mansimar. You can totally take over. And welcome to the family, everyone who's going to join.
Thank you so much, Avi. I think this goes on behalf of me and all the other Zoes too, for your kind and sweet words. And I'm like, you very beautifully condensed about what AMSA is as an organization. There's also another person that we would like to call upon to speak, is Love Gupta, the director of MND, which is our Membership and Development Department. So Love, could you please unmute yourself and say a few words?
Hi Shravya. Hello Avi. Hi Akruti, Tanya, Mansimar, everyone. It's great to have you all here and all the finalists who are here ready for the final round of the quiz. But before that, we have our amazing team of Zoes and state heads to tell you about AMSA India and all that we have to offer you as our members. So this during this membership drive, we have the maximum discounts that we have offered so far. So grab hold of this opportunity because membership drive is live for 2 more days only. So all the best. Register soon.
Thank you, Love. Thank you so much. And I think with these both amazing people saying so much about the organization, to just complement that, we have a short, sweet video compiled for you guys. So I request Akriti to just start playing the video. Thank you.
Is my screen visible?
Yeah, Akriti, it is.
All right.
AMSA India is the regional chapter of AMSA International. We are a non-profitable, non-political organization led and run by budding doctors. AMSA has a wide network of students from Asia, Asia Pacific, and beyond. With 27 chapters across the globe, we aim to share knowledge and create international and transcontinental friendships. Closer home, we are established in 23 Indian states with members from more than 215 medical colleges. Various events are organized by AMSA to give our members a chance to showcase their knowledge and skills. We participate in different international conferences like Asian Medical Student Conference and East Asian Medical Students Conference held annually. You get a chance to learn about research and teaching methodologies, practice and hone your clinical skills, and also explore the destination city. Don't have a passport yet? Don't worry. We also host and collaborate in various national conferences like Ethos, Swastik, Confluence, Remedium, and many more. One of our most intriguing and exciting events, the Asian Medical Students Exchange Program, where you get to travel and explore the academics, socio-cultural aspects of different countries, contribute through community services, and make new friends. AMSA also gives you the opportunity to compete with other medical students at different levels. You can try your knowledge at our national quizzes like Medinexus, Asclepius, and our new quiz series of Quizathon. We also have Saturday night trivia and Vocable, the crossword hunt held weekly on our official WhatsApp groups, and we organize activities at state and college levels every month to foster inter- and intra-college relationships. As medical students, it is our responsibility to give back to our society, and for that, we have the Public Health Stewardship Program. It is a set of 11 different projects run by our Public Health and Research Department to bring together medical students who want to contribute to community outreach. We have designed these programs to cover the Sustainable Development Goals as set by the UN. We also have our publications. Revista Medicos is the quarterly e-newsletter published by AMSA India. We have sections including interviews, scientific articles, essays, photography, puzzles, memes, and art, through which you can showcase your literary and illustrative proficiency. AMSA India also gives you a chance to write for international newsletters of FAMSA, CMU, and AMSA International. We are headed by a regional chairperson. They are assisted by VOCE, General Secretary, and VOCI. Helped by their assistant, they overhead departments run by their own heads and national officers. We also have our liaison officers and state heads along with college heads taking initiatives at regional levels, working together for providing our members the best experience. AMSA India is affiliated with different organizations around the globe. We have also partnered with medical education platforms for making your academic journey easier. Excited to seize the plethora of opportunities? We'll be delighted to have you in our family. Membership is open to all medical students across India. To know more, contact our M&D department or reach out to us on our website or social media platforms, or download the AMSA India app. With our vision of knowledge, action, and friendship, we aim to bring together people with similar interests and provide a platform for holistic growth of future healthcare professionals. Welcome aboard.
Thank you, Akriti, for that amazing little cute video. So if this video still didn't convince you, don't worry, we have a lot up our sleeves. And to start off, I would like to invite Tanya Pollock, the Zoe West, to start off the presentation.
Akruti, could you start sharing the PPT, please?
Yeah.
Yeah, thank you. Guys, am I audible?
Yes, you are. You can
Okay,
start.
thank you, Shraddha. Good evening, guys. Welcome to our membership drives induction session. We are very glad to have you. So, all of this about internal department being so great, all of this is true, and we would like you to witness all of this. But today is not about us, but it's about you. So, guys, we are going to talk to you about AMSA today. We're going to explain to you what AMSA is, what it stands for, and what are the different kinds of opportunities that we bring to you and your college, right? Akriti, can we change the slide? Agruti, can we change the? Yeah. So guys, our membership drive is here, and these guys will tell you more about it. Right now, we'll start by introducing. I'll start by introducing AMSA to you. Yeah. So guys, AMSA stands for Asian Medical Students Association. So guys, there's a larger institution, a larger organization, which is called AMSA International, and this organization has chapters across the world, mainly in Asia. And one of those chapters is AMSA India. So guys, AMSA India is basically a non-profitable organization. We are non-political, even though, as Avi mentioned, we do take stands. And the most important thing about us is that we are run exclusively and solely only by medical students across India, here in AMSA India, right? Next slide, please. So guys, we are an ever, okay, so our motive, our vision is knowledge, action and friendship. And using these, and like with this vision, we aim to enrich the lives of medical students by by providing opportunities at college, state and national and international level, which these guys are going to tell you about. Next slide, please. So guys, AMSA India is a ever increasing family. Right now, we have our presence in more than 250 colleges in India. And before this membership drive, we had around 3,500 members. We have 30 state heads, we have 4 zonal officers, and we have more than 220 plus college heads. And this is just our internal department. We have more departments with more members who are running this entire organization to bring the most beautiful and amazing opportunities for you, about which Mansamar is going to tell you. Over to you, Mansamar.
Thank you, Tanya. I hope I'm audible.
Yes, you are. Answer.
Okay. So yeah, starting with the international opportunities that AMSA provides, we have international conferences organized every year. There's EAMSC, that is East Asian Medical Students Conference, and AMSC, that is Asian Medical Students Conference. They are held, like, these are the two conferences held every year. And I'm proud to say that this year we hosted the EAMSC in Delhi in Maulana Azad Medical College in January. Then next we have the AMSEP exchange programs. These are the exchange programs conducted by the AMSA across borders. With the recent one we had with Philippines, which was organized virtually in the comfort of your own home. Like, we were able to interact with people across borders, and we were able to learn about their culture, about the healthcare system in their country. Uh, Next, we have the AMSA International e-newsletter. We have this e-newsletter published by the AMSA International body. And as we mentioned that AMSA India is the chapter of AMSA International. So we send entries according to the theme. And then we have the International Consortium of Clinician Scientist Trainee Organization. Next slide, please. Okay, so we were a part of the WHO CRO this year as well as last year. The 72nd session was held last year and Dr. Rohini Datta, the then RC, the regional chairperson, was the delegate over there. Next slide. So coming to the national opportunities, we have this public health and stewardship program run by the PHRD department of AMSA India. We have 11 projects under this program, which we'll shortly discuss. Then next we have the national conferences. We have an upcoming conference in the next week, the AMSA Con, which is online, and we have a variety of events under that. Next, we have the leadership development program. Then we have national quizzes. We have our very own series of national quizzes, that is Quizathlon, and we conduct various academic as well as non-academic quizzes under that. And the one which we are conducting under the AMSACon is the Marvel quiz. Next, we have the health camp. We have organized health camps in association with CRY Foundation in the past, and we plan on conducting such events in the future as well. Next, we have the 1 million project. Next. Then the other opportunities that are available on a frequent basis, we have the Saturday night trivia, which is conducted every Saturday on your WhatsApp groups, the official AMSA WhatsApp groups, where you are added after you become the member. We have this quiz organized by the academics department of AMSA. Next is the Vocable the Med Trail. This is organized every Wednesday at 5 p.m. in the WhatsApp groups. Then we have the college head activities. The college head in your college organizes an event every month, of which you can be a part of. And then we have the quizzes, the online activities and competitions. And then there is Revista Medicos. It is the newsletter published by AMSA India quarterly with a new theme with every quarter. Handing over to Akruti.
Yeah, thank you, Mansimar. Moving on to MARROW, which is the Medicals Education and Research Society of AMSA India. It is the newest department that we have in AMSA India. It was started only this year, but the aim is basically to advance and pioneer research among medical students, mainly undergraduate students, because research is something that we generally tend to not focus on until PG. So the aim would be to give you or provide you with research opportunities that are not bounded by limits. There will be guidance and support from the MARROW team, as well as professors that we will bring on board eventually. And it's a place where you can have limitless ideas and support for those ideas to help you figure out how to conduct research and how to go about publishing it after you've done it. Followed by, we have, like Mansimar said, the PHRD department, which is the Public Health and Research Department of AMSA India. So they're running the public health stewardship program designed around the sustainable development goals set for 2030 by the WHO. So these are a couple of the events that were conducted by the PHRD department this year. So there was Raise a Glass done by Ahar Abhiyan, which is a project that's helping with malnutrition. And we have Wear the Pride, which was done by Project Samya. That's speaking about gender inequality. No Tobacco Tuesdays and Ujjwal were a couple of other projects that they undertook. Handing over to Shravya.
Thank you, Akriti, for that. So I will be talking about the activities conducted, and I'm talking about the basic, simple activities which start at college level. So you can only imagine the diverse activities conducted because we have 250 plus colleges all over India. So this one line kind of condenses it. So from academics to awareness sessions and from quizathlons to marathons, we have everything. So moving over to the next slide, a few of the sessions conducted, and one of our best highlights was Project 1 Million. So what was Project 1 Million? It was a collaboration with an NGO where we went to kids, like we went to girls' school kids, and we taught them about menstrual hygiene, about sanitary hygiene, and how to stay healthy during their periods. And we distributed 1 year's supply worth sanitary pads and other commodities to these school kids. So this was one of the best and most impactful projects, according to me, in AMSA India, and there are many more like these. So going to the next slide, but the different awareness sessions. So these awareness sessions can be in collaborations with schools. It can be collaborations with like NCC, NSS, and it can be in your own colleges, because as we know that in the medical fraternity itself, we have so many things prevailing like mental health, anxiety, depression, etc. So these awareness sessions started from our very own colleges and went across to schools and other colleges too. So the next we had interactive sessions with again school kids, and also in those schools we went across, we tested, the BP and the hypertension and sugar of the teachers of that school. So now a question arises, why do we need to do all this? Because I feel as a medico, our responsibilities go much ahead of academics, and AMSA gives you a platform to do that. AMSA gives you a platform to go to schools and talk to kids or go and conduct health camps. So if you want to do it, we will provide you the opportunity to do that. But you must be wondering, in this pandemic, how is all of this going to be possible? And you're stuck at home. But worry not, we've got you covered for that also, because we have an array of online events every single month conducted by every single college all across India. So the online events range from quizzes, charades, debates, webinars, awareness sessions, and much, much more. And I think one of our best highlights, I'll not take much of your time. I'll hand it over to Akriti to talk one of our best upcoming events. So Akriti, over to you.
Thank you, Shravya. So, we have a very exciting event. It is our largest conference that we have ever planned, and that we are planning for the 7th to the 15th of October. It's called AMSA Con. There are basically a lot of events that are being planned under it. So there's academic competitions, right, ranging from your scientific paper presentations to poster presentations to public health infographic presentations. We also have an MUN that the PHRD department is planning. We have a virtual escape room that is based on some of maybe your favorite TV shows and movies. A virtual concert called Love Unplugged in association with a foundation that is basically going to contribute all the funds towards acid attack victims and survivors. And we have, of course, the Quizathlon, which is our national quiz, the third one that's being conducted in the past 3 years. And we have the second round that's happening now as part of AMSACon. So the registrations for which are open already, and we will share the booklet with you on the group. The registration links are in the group, and all of you who become members now are also eligible to apply as members for AMSACon. There are also events that are open to non-members, so feel free to join in. Now, for our membership drive, how do you become a member? So there is a Plexus MD link that we will be sharing with you in case you don't have it already. You just have to click on the portal, decide whether you want to register individually or as a group of 10. Individually, our normal membership fee is 1,000 rupees, but solely between the 22nd and the 28th of September during our membership drive, we brought it down. So individual registrations are 800 rupees per head, and a group of 10 people pay 6,500 for the 10 of you. So once you register via the Plexus MD link, you'll get a registration ticket on your email. After which you just have to approach your college head if you have one, and if you don't, approach any of your state heads. If you need contact information for any of them, you can approach any of us. We'll lead you to them. And then finally fill up the registration form, the AMSA membership form, with your membership ID that your college heads will allot to you, and you're part of our family, and we can't wait to have you. Yeah. If you have any questions about this, feel free to put them in the chat box, or yeah, Shravya, over to you.
Okay, thank you so much, Akriti. So I think that's all that we had to say, and we kept it right under 20 minutes. And this was, again, everything that covers AMSA, about what it is as an organization, of how it benefits you as an individual. Now it's your opportunity, like it's your time to grasp the opportunity and come be a part of our family. So do not lose out on this opportunity, because it's really, really nice. And it takes you much beyond just being a regular medical student. So that wraps up the induction session of the Membership Drive 2020. You're free to contact any one of us, all four of us, and we are more than happy to answer your queries. You can leave them in the chat box or in the YouTube comment section. We will definitely go through, we will definitely get back to your queries. And that's all from our side. Thank you so much. Thank you so much for giving us this platform. And over to you, Bhavya. All the best to all the quiz participants. Have a great day.
Thank you, Shravya. First of all, I'd like to invite our esteemed our esteemed faculty members here, Dr. Amir, who is the coordinator of MU for UCMS and GTB Hospital. So a very warm welcome to Dr. Amir. Then we have Dr. Mrinalini, who is a professor in pathology at the UCMS and GTB Hospital. And also from the pediatrics department, we have Dr. Dheeraj Shah. So a very warm welcome to all the esteemed faculty members who've taken so much their time for us. So I welcome you all on the behalf of AMSA as well as ILLUMINOUS, who's working Quest Society for the UCMS. Over to Satyam and Mimansa ma'am. Satyam sir and Mimansa ma'am.
Hello, good evening to all the participants. I hope everybody has joined in the meeting right now.
Yes, ma'am. Like I assume just a gentle reminder to all the participants. If you could just write your team like A, B, C, D in front of a name, that would be easy for us to just, assess it. Thank you.
Yeah, and one more thing, all the teams are supposed to nominate one member who will be the speaker for this entire quiz. And both the members, as we have intimated earlier, are supposed to stay connected on the call. So that one member who's supposed to be the speaker should name themselves as Team A1, and the other member should name themselves as Team A2. Please do this within 5 minutes.
Meanwhile, if we can have a few words of initiation as well as a vote of kind of good luck or all the best from Dr. Amir to our participants, that would be great. So if we can listen from you.
Thank you. And thanks to AMSA and also the MARROW and all the medical education unit members and the faculty in charge of medical education unit, Dr. Dheeraj. Dr. Mrinalini is also a member of medical education unit, and earlier those who have nurtured medical education unit of UCMS and GTB hospital for the vibrancy that we should see today and the culture that we follow in our MU, those credits go to Dr. Navjeevan Singh and Dr. Piyush Gupta. You students lead the whole idea of medical education, and I think that a college should be like of the students, for the students, and by the students. We faculty and the other infrastructure and other staff that is available in the college, its main role is to facilitate your growth, the growth of your ideas, your vision, and then that idea should go into the society. And this is how our institutions, I think, will shape up the societies. With the ILLUMINOUS Society, I and the whole medical education unit is very happy to see how it has grown, how it has brought the quiz as one of the very potent mediums of medical education. So I would not waste your time in these nitty-gritties, but you all are doing a fabulous job. We are there to support you whenever you need our help, our support. But in fact, I feel that we all bask in your glory, and we are happy to have that. And we will try our best to make our campuses vibrant and our students vibrant. And as Chetna Dengri was the one around more than 1 year ago when she thought of this idea of Illuminous. And then we started a student section unit in a medical education unit, because till that time, medical education unit's main role was only the faculty development program. But we thought without students, medical education will not be what it should be. So I think that that is all I have to say. All the best to all the teams. Thank you for participating, and thanks to Illuminous and Mimansa and Bhavya and all your team members to taking it ahead and forging new partnerships, new collaborations, and expanding the idea of medical quiz in a very positive light. I would like Dr. Dheeraj as a faculty in charge to also say a few words because I am blessed and I'm thankful to his support since a very long time. And he is also very student friendly, as Dr. Mridalini and other MU members also are. Thank you, Dr. Bhavya.
Thank you, Dr. Amir. And it's indeed heartening to see this initiative now reaching this level, final level. So as Amir said, that the medical education is like it's for students, but it is also students, and great to see that this alternative learning strategy has been initiated by the students, and it has reached this stage. Today, I think it are the finals of this quiz. So I wish all the finalists very good luck, and just remember that it's just one of the alternative learning strategy. So there is no winner, no loser. Everybody who participates in this quiz is a winner. With these words, I thank Mimansa, Bhavya, and all these wonderful students who have organized this quiz as an alternative method of medical education on their own initiative. That's the greatest thing about this. Thank you all.
Thank you, Dheeraj sir. Mrinalini ma'am, can we have few words from your side to enlighten us?
Yeah. It's really heartening to see all of you again together in this COVID time, when you all have joined together, and through virtual media you have been able to organize this quiz. I remember the time when Chetna approached all of us to start with an initiative like this, and now it has reached this proportion. So it's really good, and we are really proud of you all and how enthusiastically you have brought this quiz to this level. Really proud of you all, and I wish best for all the participants. And as Dr. Dheeraj just said rightly, there are no winners, no losers, and the spirit of participating is the most important one. And the journey which you all spent together, it's invaluable. For the organizers, I think it's a wonderful journey, and I wish you all the best for many such events in future. And I wish you all the best for this. Thank you. Hello.
Sir,
Thank
Satyam,
you,
sir, you're
Mrinalini
muted.
ma'am.
Satyam sir, you're muted, I think.
Thank you, Mrinalini ma'am, Amir sir, and Dheeraj sir for those words. With this, we would like to start the final round, the last hurdle, the final round of the Integrated Quiz 2020, organized by ILLUMINOUS, the Medical Quiz Society of UCMS. And so I would like to introduce the participants first. From around 320 participants, we had six finalists. So we have Team A, Bala and Arman. We have Team B, Rakesh and Vishwatha. Team C, Anirban and Soumya. Team D, Harsh and Ayush. Team E, Dakshin and Pranav. And finally, we have Team F, John and Vidyasagar. Can we see you all, guys? Now I would like to hand it over to Anukriti and Anjali.
All the participants. Guys, please switch on your videos. Harsh sir, you both have joined through a common Zoom link. Team D, Harsh sir.
Yeah, both of us are in the same. We are using the same account. Team D is only using
Okay,
one account. Both of us are here.
okay, but sir, despite that, only one of you can speak up the answer.
Okay, that's fine.
Okay.
Hello, excuse me.
Manta.
Okay. Sorry. There was a technical glitch from my teammate. It got resolved.
Okay, so I guess we are good to start. I'm handling over to Anukriti and Anjali. Anukriti, please.
Yes. So, hello everyone. Me and Anjali are going to have the first round. So, the first round is Potpourri. First question, ma'am. Can we start? So first of all, the rules, as you all know, this is the first round of the quiz, and it will be a pounce and bounce round. This round has a total of 6 case situations, and the pounce window will be open for 30 seconds after the quiz master has finished reading the question. During this period, the teams have to send their answers on the respective WhatsApp groups, and not the main group. Okay, correct pounce carries 20 marks, and a wrong pounce is -10. The team who has got the question as a direct can also pounce. After the pounce window closes, we will go in an orderly pattern that is passed to those teams who haven't pounced. No negative on bounce or passed, and the correct answer is +10 for direct or pass. Any confusion on this?
Excuse me, will the
I
question
hope everybody. Yeah, please.
will the question pass to all the teams in orderly fashion?
Oh, hi. The questions will be passed to those teams who haven't pounced.
Okay.
Yeah.
If they answer correctly without pouncing, how much they get? 10 points.
+10. Yeah. So any confusion, anyone? I guess no one has confusion. So we'll start the first round from team A.
So moving on to our first question. Can we move, guys?
Yes.
Okay. Ma'am, next slide. So the first question is 72-year-old female with acute abdomen. The abdominal pain began acutely 12 hours ago. It was a sharp pain experienced in the epigastrium and left upper quadrant. There was no radiation, no reliable provoking or palliating factors. Patient rates severity of pain as 7/10. Review of systems otherwise is unremarkable. History of past health unremarkable. No known chronic medical conditions, no regular medications, no allergies, non-smoker. And on physical examination, he looks well, but clearly in discomfort. Vitals are heart rate 92 beats per minute, BP 125/75, respiratory rate 12 per minute, oxygen saturation 98% on room air, temperature 37.8 degrees Celsius. All other systems are normal. Head, neck, cardiac, respiratory, neurological, peripheral vascular examination, all are normal. Abdominal examination, normal appearance, normal bowel sounds, normal percussion notes. Tenderness to palpation in left upper quadrant. No peritoneal findings. No masses. All organomegaly. No evidence of ascites. Next slide. Ma'am, next slide. On laboratory investigations, hemoglobin was 14.4 gram per deciliter, WBCs were 14.3 millimeter cube, platelets 1,50,400 per millimeter cube, electrolytes, renal functions, glucose, all were normal. AST was 15, ALT 16, ALP 83, bilirubin 0.4 milligram per deciliter, lipase was 42, INR 1, PTT was 29 seconds, and lactate was 2.3 millimole per liter, and troponin was 12 nanogram per liter. As you can see the ECG, what is your possible diagnosis?
The Pounce window is open. The Pounce window is now closed. It's direct for team A.
Inferior wall MI with heart block. Hello?
Yeah, moving on to the answer.
Yeah, it's in inferior wall MI with heart block.
No, that's incorrect. The answer is atrial fibrillation causing splenic infarct.
Are the answers supposed to be passed in this round, or is there no passing?
Yeah, actually it was supposed to be passed, so there was some misconfusion. The next question will be passed to everyone.
Shall we move on to the next question?
Yes, ma'am.
Team B, are you ready?
Yeah.
Ready?
Yes, yes.
Okay.
Question number second is on October 16, 2001, a 47-year-old male postal worker developed progressive nausea, abdominal pain, and flu-like symptoms that prompted him to seek emergency medical care 5 days later. Chest radiographs obtained on the presentation to the emergency department revealed a subtle parenchymal lung infiltrate limited to the right suprahilar region. The patient was sent home with a presumptive diagnosis of gastroenteritis. He continued to deteriorate and on the following day was taken to the hospital by ambulance. When he arrived, signs of shock were already present. Sequential chest radiographs showed rapid progression of airspace disease, perihilar infiltrates, pleural effusions, and mediastinal widening. Post-mortem examination showed hilar soft tissue perivascular and peribronchial hemorrhage. What is the new drug approved for this disease and which might have been used back then to save the person if a timely suspicion was made?
The pounds window is now open. The pounds window is now closed. Team A, Team B, and Team F has pounced, and also Team E has pounced. So it's now direct to Team C.
We'll pass it.
Okay. Should we answer?
Yeah, now Team D.
Yes, sir.
Is it tecovirimat?
So can you please repeat?
Is it tecovirimat? Tecovirimat.
So what is the diagnosis that you've made in this case?
Pulmonary anthracosis. Anthrax, basically. He has widened mediastinum and hemorrhagic mediastinitis. So this is pulmonary anthrax, and it's a very characteristic 2001 enveloped terrorist crisis history.
Yes,
The
sir,
drug
correct.
is probably tecovirimat.
नहीं है तो स्मॉल पॉक्स बोल दूं
Hello, we had, I think, Team E2 talking right now. Is it something that you want to say?
सॉरी मैंने गलती से अनम्यूट कर दिया सॉरी
अच्छा, okay.
Anjali, can we now move to the answer?
Yes, ma'am. Next slide, please. Ma'am, next slide.
I'm doing it. There's some kind of a delay, I think.
Okay.
Yeah.
So yes, the diagnosis was initial anthrax, and the drug was raxibacumab. Also, some of the teams answer oxaliplatin, which was also correct. So Team A, Team B, Team E, and Team F gets plus 20 on pounds, and Team C gets a 0, and Team D gets plus 10 on direct.
Can we move to the next question?
Yeah, next is direct for Team C, right? Is Team C
Yes.
ready?
Yes, we are ready.
Okay.
So, a 71-year-old woman with rheumatoid arthritis presented with a change in bowel habit, fatigue, abdominal discomfort. The CT scan revealed hepatosplenomegaly, lymphadenopathy, particularly in region of splenic hilum. Waldeyer ring was also found to be involved. The CBC revealed pancytopenia. Hemoglobin was 10.2 gram per deciliter. WBCs were 2,400 per microliter. Platelets were 95,000 per microliter. The bone marrow biopsy revealed mild hypocellularity with tri-lineage hematopoiesis. There was no history of sweating, weight loss, or any recent infection. The serum proteins were raised, and immunofixation showed monoclonal spikes. Gel electrophoresis, immunotyping, urine immunofixation also revealed the same results, and the results were again confirmed by a second gel electrophoresis. The drugs were given to the patient, and she was monitored on a 3-month basis. What is your diagnosis?
The pounds window is now open. The pounds window is now closed. Team A and Team B has pounced. It's now direct to Team C only. Also, Team F has pounced.
Hemophagocytic lymphohistiocytosis. No idea, bhai.
No. Team D.
Waldenstrom macroglobulinemia.
No, sir. Team E.
Is it gamma heavy chain disease, also called the Franklin's disease?
Yes. Can we move to the answer? It's Franklin disease, immunoglobulin G heavy chain disease. Can you please unmute yourself?
So we get a +10 for Team E. The rest of the 3 teams have pounced. Only F team is correct. Team A and Team B gets a -10.
Excuse me.
Yeah.
क्या कहते हैं वो जो LGL होता है that is also associated with Franklin disease and इसमें Felty syndrome के बाकी features भी हैं with due to LGL तो सारा cross वो associated ही होते हैं साथ में मतलब LGL is also related with Franklin disease तो Felty due to LGL भी तो सारे match हो ही रहते हैं.
Okay, Arman will actually look into this and will actually keep this on hold and get to at the end of the quiz.
Okay.
Thank you.
Can we move on to the next question, please?
Is Team D ready?
Yeah, we're ready.
Okay.
A 70-year-old male was admitted because of hemoptysis. He had sympathectomy at the age of 42 due to arteritis. Since then, he had had several episodes of DVT. He has no organ or genital ulcers. CT arteriography showed aneurysm for the right bronchial artery. CT pulmonary angiography demonstrated an aneurysmatic dilatation of the pulmonary artery. Bronchoscopy showed compression of the intermediate bronchus and distal part of the left main bronchus with dilated submucosal blood vessels that were bleeding lightly to the touch of bronchoscope. Immunological tests revealed antiphospholipid syndrome. What is the probable diagnosis?
The pounds window is now open. The pounds window is now closed. We have a pounds from team C, team E, and team F. Since it was a direct for team D, so we now go to team D.
Is it catastrophic antiphospholipid syndrome?
Sorry, team D. Now we move forward to team A because team E and F has pounced.
A pass.
Now, actually, we don't have any negatives on bounce if you want to try.
I was going to tell caps only, but it was wrong. So pass.
Okay, team B.
The Rasmussen aneurysm associated with bronchial fistula.
No, now we have team D. Team D, would you like to answer?
This was our direct. We've already answered. Caps
Oh,
and-
fine, my bad. So can we have the answer? It's Hughes-Steuben syndrome, and team C, E, and F gets correct on pounds.
So now, can we move to the next question?
It's a direct for team E. Is team E ready right now?
Yeah, we are ready.
Okay.
So, a 73-year-old female sent to the cardiology clinic for surgical clearance in preparation for an elective cholecystectomy. Her current complaint is shortness of breath with minimal exertion. Review of symptoms was remarkable for left arm pain with repetitive movement. Occasionally, she would also experience blurry vision, dizziness, lightheadedness, and syncopal episodes with the same activity. Physical examinations revealed BP of 140 by 80 in the right arm, 110 by 60 in the left arm, heart rate of 70 beats per minute. The left radial pulse was diminished. Cardiac auscultations revealed a 2 by 6 systolic ejection murmur over the right base. Bilateral carotid bruits were noted. Lungs were clear to auscultation. Pulses in lower extremities were intact. Few months later, she had an episode of MI with a two-vessel multifocal blockage for which a procedure was performed. Now she presents with heaviness and dull precordial pain every time she does kitchen work with her left arm. What are we dealing with?
The pounds window is now open. The pounds window is now closed. Team C, team A, and team D has pounced. So it's direct to team E.
Is it Takayasu arthritis?
No, team E. Now we F.
Coronary steel phenomenon. Hello.
Yeah, it's not coronary steel. Can you please make it better?
Sorry, subclavian steel phenomenon.
Yeah, that's right.
Yeah, you're right. Can we move to the answer? It's subclavian steel syndrome.
So we have team D correct. We have team C correct. We have team A. Can you explain the why you have reverse steel phenomena and not simple subclavian steel?
Because the patient is having dull pain in the precordium while working, so that means that initially the patient had a stenosed subclavian artery, and then after she had an MI, then she would have undergone a grafting for the same procedure with Lima, and that would have led to now the pain in the precordium because of working, because that Lima would also be having the reverse flow. The subclavian steel should not be accepted since he's having precordial pain, that is angina. So that will not be seen in subclavian syndrome. It will be seen in reverse subclavian steel syndrome.
The
I think
ideal
Arman is
answer which
away.
I was expecting in this question is coronary subclavian steel phenomenon. Because initially she was having subclavian steel syndrome, which is now progressed to blood into the coronary artery. So
Yeah. So
I
that occurs
think
only after the graft.
CABG,
Yes.
right? I accept that, but I think we'll give it to team
Hello.
A, C. Yeah.
Sorry to interrupt, but Takayasu arthritis can present with subclavian steel, right?
Please see the age group in this case. It's 73-year-old female. I don't think Takayasu does that.
Okay, fine.
Yeah. And also to correct, I think Team C has given us subclavian. Hello.
Yeah.
Yeah, I think Team C has given it as subclavian artery aneurysm. It's not subclavian artery aneurysm, though subclavian steel is correct, but it's not due to an artery aneurysm. We haven't given the history of aneurysm anywhere in this.
No, the here actually there was some pain. The steel can cause some pain if it the irritates nerves at the outlet, right? So we thought that a like grossly atherosclerotic picture is going on in the whole large vessels. So
Can you
it,
please
it
turn the slide back to the question?
Yeah, sir, I'm trying to do that, but I'm afraid I can't go back. So,
So are we
I
getting the
agree with
marks for
what
this
Arman is
question?
saying. Coronary
yeah, I
subclavian
think
steel is not the same as subclavian steel. There has to be a
Yeah.
history of CABG, and subclavian steel does not have a history of CABG.
I
They're
think
Yes.
we'll
totally
give
different
it to team.
Yeah.
and this patient
Yeah,
only
I
has
think we'll give it to team A
subclavian.
and D. Plus 30 to sorry, plus 20 to team A and D. Hello, team. Is that no?
Yeah. We got. Okay.
So do we move on to the next question, please?
Yeah, is team F ready for the direct?
We are ready.
Okay.
So, a 43-year-old woman who was complaining of a sudden decrease in visual acuity, which occurred after she had surgery for a ruptured intracranial aneurysm. She was diagnosed with rupture of a posterior communicating artery aneurysm, which was clipped along its origin from the internal carotid artery. 2 weeks postoperatively, the patient accused of a sudden decrease of visual acuity in both eyes. Upon examination, the patient presented with BCVA, that is best corrected visual acuity in right eye 0.3 and BCVA LE 0.02, normal IOP and no significant changes in the anterior pole. Next slide. On right eye fundoscopy, we were shown this. Give the diagnosis.
The Pounce window is open. The pounce window is now closed. Only team C has pounced. Now can we go directly to team F?
Uh,
Can you please go back if possible?
yeah. Hey, நம்மளுக்கான question.
Thank you.
Uh, hello, hello, hello. Can you hear me?
Yeah.
Uh, we would like to go with uh, anterior communicating artery aneurysms. A leftover aneurysm is present.
I'm afraid it's not. Can we move on to team A?
CR reversible.
It is due to clipping of ICA along with posterior communicating artery aneurysm.
Sir, what is the name of we're looking for a specific name.
Don't know.
Okay. Next team.
Team B.
Optic neuropathy presenting as acute pain issue.
No, that is wrong.
Team D. Team D. Harsh sir, Ayush sir.
Is it AION, anterior ischemic optic neuropathy?
No.
No sir. Team E.
Is that optic neuropathy?
No, sir.
So for this, the answer is
Terson syndrome is the answer.
syndrome. Yeah. So it plus 22 team C for getting right on pounce.
Next slide, I guess. Okay,
So
guys,
with
first
this
round
we
is
come to
over.
the.
Yeah, ma'am, go
Can we
ahead.
have the scores? Bhavya, can we have the scores, please?
Yes, ma'am. So team A has a total of 30, team B 10, team C 40, team D 30, team E 50, and team F is leading right now with 60 points.
Hello, ma'am. Hello.
Oh, yeah.
We have a discrepancy. We actually scored 70 points. We got 3 pounds right and one bounce
Yeah,
right.
yeah. Team F is 70.
I'm sorry, I'll just update that.
Guys, we apologize for any kind of discrepancy because this is our first online quiz. Before this, we have been conducting live quizzes, but honestly, this is our first experience with them.
How many points does Team D have?
Team D have 30. 40, my bad. 40.
Team D.
Yeah, D.
Can you just share the marking scheme? I mean, which questions you were scored on?
So I'll do that. Hi, we have shared the scoring on the WhatsApp group, the main WhatsApp group. You can check it there. A correction, Team D actually had 30. Sir, you had plus 10 on anthrax, and you had plus 20 on the coronary still phenomena. Rest was no. Team D.
Thank you.
So shall we proceed with the next round?
Excuse me.
Yes.
Have you considered our answer, the previous answer, LGL in place of Franklin disease? Because all symptoms are explained with that.
We are still looking into it, Bala.
And also Franklin associated with LGL. So please see.
Yeah, we are looking into it.
Okay.
Can we
Thank
start
you.
with the next round? Yeah, welcome. Okay.
So our second round is the connect round. Can we move to the connect? Which team is it supposed?
We are direct to Team B. So if we are going from the pattern, the first round goes from Team A, B, C, D. The second round goes from Team B, C, D, E, F, and finally A. So we have 6 rounds, and every team will get the first round and first question.
Okay, so question number 1, which is direct for Team B. So is Team B ready?
Yes. Is this a bounce round or?
Yeah, it is. It also has bounds and bounds.
Yeah, and one more thing, for instance, this is a connect round, right? So if you have 5 images in the matrix, you are supposed to tell 4 images at least with the connect. Likewise, if it has 4 images in the matrix, you are supposed to tell 3 images with the connect. Anukriti, please go ahead with the rules.
Okay, ma'am.
Excuse me, we have to explain the images in pounds?
Yeah, you have to explain the images in the pounds as well. At least 3 images out of 4.
I'll be reading the rules. This is the second round of the quiz, and that also will be a pounce and bounce round. This round has total of 6 connects. The pounce window will be open for 30 seconds after the quiz master has finished reading the question. During this period, the teams have to send their answers on the respective WhatsApp groups and not the main group, as we were doing. Correct pounce carries plus 20 marks, but a wrong pounce will lead to negative 10. Correct pounds will only be considered when the connect plus explanation of the images is given. At least 3 by 4 images have to be explained. The team who has got the question as a direct can also pounce. After the pounce window closes, we will go in an orderly pattern pass to those teams who haven't pounced. No negative on bounce or passed. Correct answer plus 10 for direct and pass. So, are you ready for the next question? The connect?
I have a doubt. How much time will we get? Because I don't think you will be speaking out the question in this one. So are we getting 30 seconds or some more time?
So the pounds window will be open for 30 seconds.
Okay.
And then the page, and then the direct will go.
Okay, thank you.
So can we move to the connect?
Team B.
Yes.
Okay.
So now the pounds window is open. The pounce window is now closed. Team B can directly answer.
Pass.
Team C.
Is it Beckwith-Wiedemann syndrome?
Sorry, it's not Beckwith-Wiedemann. Can we have Team D?
Pass, we don't know.
Team E.
Any small round blue cell tumor associated with omphalocele?
Can you repeat?
A small round blue cell tumor associated with omphalocele?
No, Team A, because Team F has pounced. Team A.
Down syndrome.
No. So the answer is. Can we the next slide, answer? So the answer is Perlman syndrome. That's the image 1 was showing hepatomegaly. The image 3 was showing omphalocele. The image 4 was showing Wilms tumor. It was very similar to Beckwith-Wiedemann as Team F answered, who gets a -10 negative. The image 2 was showing some special facial features which puts it apart from Beckwith-Wiedemann. So the answer is Perlman syndrome.
Shall we move on to the next question?
Yeah.
Okay. Is Team C ready?
Yes.
Okay. The pounce window is open.
The pounce window is closed. So now this question goes to Team C. Team A has pounced and Team E has also pounced. So it's direct to Team C.
Is it gastric valvulus?
No, it's not gastric valvulus. Only one image was explaining that. Can we go to the next team? Team D.
Are these different types of ulcers, stomach ulcers? Cameron, curling.
No, sir. Only two images were explaining that. Can we move on to Team F?
Cecal volvulus.
No, it's not cecal volvulus. Can we move on to Team B? Team A has pounced.
Pass.
Pass. Can we? So it was a direct for Team C. Now can we have the answer? So this was rolling type of hiatus hernia. The image 1 shows Hill's operation. The image 2 was showing rolling hernia. There's an increased chance of volvulus. And the last image was Dr. Cameron from House MD showing Cameron ulcers. So team A gets a +20 on this, and team E gets gets +10 because they haven't given the whole connect. Team E. So we have team A getting plus 20 and team E getting a minus 10 because the pounce was incomplete. Can someone from team E answer?
Yeah.
So team E, you are getting a minus 10 because the connect was a bit incomplete and you have just explained 2 images.
Yeah, but it was high to Sonia, right? So I
But you
gave
have
that.
explained just 2 images. I have asked for 3 images.
But even then, a negative marking isn't needed in this question, right? I have got the answer right. Maybe
But
I didn't explain the third clue for it.
Okay, fine. Then we'll give you a 0 on that because we are not reducing the marks as well.
Yeah, it's okay.
If on pounds, if an answer is not perfectly according to what you have demanded, then you're always given a negative. At least on pounds, if not on direct.
So let us consider then on the team.
So, but I think since they've given 2 images and they connect, I think it's right on our part to give them a 0 instead of a negative. Can we move on to the next question?
And again, a warning, guys, if you are pouncing, so please give the correct answer, the whole and the correct answer.
Yeah.
Excuse me.
Yeah.
What is the final marks decided for Team E then? For this
Team E, right?
for this question.
You're getting a 0 on this question.
Okay. Thank you for the clarification.
Okay. So next question is a direct for Team D, right? So is Team D ready?
Ready.
Okay. Pounce window is open.
The pounce window is closed. No one has bounced. It's direct to team D.
I think this is ASD. Bubble contrast echocardiography is the investigation of choice. It has a fixed split of S2, right axis deviation, and I don't know what the ECG is, but I have 3. So if that's the correct answer.
So can you be a little more specific for this ASD? Matlab, sir, ASD is right, but there is something which is adding more specificity to this question.
Is it ostium primum ASD? Not exactly sure what you're looking for. I thought it explained the images, that's all.
No, sir. I think we'll give you a mark for this, plus 10. But sir, it's actually ostium secundum. The fourth image is crochetage sign, which is seen in ostium secundum. And in ASD, we have 2 types of deviation. It can either be an LED, which is an ostium primum, or it can be right axis deviation, which is an ostium secundum. So we were looking for ostium secundum, but ASD is also fine. Team D gets a plus 10 for this question. Can we move on to the next question for Team E?
Yes.
Okay.
The pounce window is now open.
இது அந்த எபிகாந்தல் ஃபோல்டு மாதிரி இருக்கு.
Team
கேட்டைடா, கேட்டைனா
Team E, your mic is on. Can you mute your mic? Team E1.
கேமல் எதுக்கு வந்துச்சு? ஏதாவது நூனான் அந்த மாதிரியா?
The pounce window is now closed. It's direct to team E.
Team E, can we have your answer?
Do we have a negative for this question?
No.
If we answer wrong, no. Okay.
No negatives for direct.
Is it epicanthus inversus?
Can you explain all the images?
Is it that BPES syndrome?
Can you explain the images? Team E, please do it quick. I'm afraid we don't have that much time.
Yeah, is it FOXP3 mutation or something like that?
I'm sorry, we can't give you a
Huh?
mark.
No
Firstly,
problem.
because no, it's not Fox P3. That's right. It's
Hello,
Fox,
ma'am,
but it's
ma'am.
not Fox.
Hello, hello.
Yeah.
We have to.
Yeah.
We can take a chance, right?
Okay.
Next.
Yeah.
See, ma'am.
Yeah. Take it.
It is FOXL2 mutation associated with ovarian dysfunction and blepharophimosis tosis epicanthus is depicted in the first image. So we answered 3 questions.
What's your connect?
BP is blepharophimosis tosis epicanthus syndrome. Epicanthus inversus
Specifically?
BP is type 2. Type 1. Type 1. BP is type 1. Fox L2 mutation, premature failure will be there, and fourth picture depicts the findings, epicanthus inversus and this.
Okay, I guess
We
we'll give a
answered
plus 10 to. Yeah.
Okay, thanks.
So team F gets plus 10 on this. Now can we have the next question? Direct for team F again.
Ready?
Yeah, ready.
The pounce window is open. Okay, the pounce window is now closed. It's direct for team F. Can we have the answer?
These are signs of liver failure. Like dupuytren's contracture is there. Where another? Liver is mentioned there as to explain. Peritoneal dialysis picture is there. Screen then
I am afraid it's not a liver failure. And that's so can we move to team A? Team A.
Alcoholic liver disease.
No, it's not alcoholic liver disease. Team B.
Is it McCune-Albert syndrome?
No, it's not McCune-Albert syndrome. Team C.
No idea.
Team D.
Is it neurofibromatosis?
No, sir. Team E.
Is it alkaptonuria?
No, it's not alkaptonuria. Can we have the answer? So it's halothane. The two images, contracture and coffee, was showing caffeine and contracture. That is the caffeine contracture test. The liver was showing halothane hepatitis. The shake was halothane shakes, and it was the picture of malignant hypothermia, which is most commonly preceded by halothane. Can we have the next for team A direct?
Is team A ready?
Yes.
Okay.
The pounds window is now open. Pounds window is now closed. Can we it's direct for team A. So can we have team A answer it?
Type 4 hypersensitivity. Poison ivy, rheumatoid arthritis, and blood showing type 4 hypersensitivity.
Yes, I'll be giving you marks for this. This is type 4 hypersensitivity. Can we have the answer? Plus 10 to team A. Can we have the scores, Bhavya?
Yes, so team A at the end of round 2 gets 30, so the total becomes 60 after both rounds. Team B gets a 0 in round 2, so the total is 40. Team C get 0 in this round 2, so their total remains 40 itself. Team D got 30 in round 1, 10 in round this, so their total is 40. Team E got 50 initially, 10 now 60. And Team F got a minus 10, so their total is 60. Let me know if there's any discrepancy.
Hello. We got minus 10 and plus 10. Plus 10 in the previous question. So in this round.
Yeah, team F is 0.
Okay.
Excuse me. We are 30 marks were increased, so total is 90 now. 60 was made at the end of the second after the first round.
Actually, we're keeping Felty question at hold right now, so that's
LGL hold. Okay.
Yeah, the Franklin one.
So can we move on to the next round? Round 3. Okay, so for round 3, we have Akshay and Satyam. Akshay and Satyam, please take over.
Everyone, I am Satyam Gupta. So I'll be explaining you the rules for this round, and then Anjali will be taking over the round because I took over a round. So can we have the rules, Mansa? Next slide. Okay, so this is the round 3. There are total 12 questions in this round. Each team will get 2 questions as direct. There is no pounce and bounce in this round, so you can keep your phones down. The correct answer will get +10 and there is no negative marking. So you can score a maximum of +20 in this round. This round has pair of 2 subjects, which the team which is leading will choose out of the 6 pairs which are made by the quiz master. So we'll have 6 images, which will have a hint of the 2 subjects. Okay, so the team which is leading will have to choose first and then we'll go in the same order. Fine. So we have currently team A and so can we, Bhavya, can I have the marks accordingly and who is leading?
Shall I tell the total score of leading or just the round 2?
The total score.
Yeah, so total score, team F is still in the lead with 70, followed by team A and E with 60.
And the next teams as well. Can you tell me the score of all the teams?
And team D and C have 40. Team B gets 10 at the round of like the total.
Team B.
D has 40.
Team C.
C has 40 as well.
Team D.
B, you mean B for ball, right?
D.
D. Yeah, I'll just tell you once again. So team A is 60,
Yeah.
B 10, C
Yeah.
40, D 40 as well, E 60, and F 70.
Thank you. So we'll have team F choose the pair first and then we'll go accordingly. F, A, E, C, D, and at the end B. Okay, so can we have can we have the next slide? So these are the six pairs which are available. So say team F, which is the pair you would like to go with? 1, 2, 3, 4, 5, 6. Team F. Is team F there?
Yes.
So which is the pair you would like to choose?
We will take third one.
Okay, so can we have the third one answer?
Oh, Nalanda.
So this one has surgery and hematology. Can we move on to the question, team F?
Yes.
The question says, 36-year-old woman presented with back pain and fever.
Ma'am, we can't hear you.
Sorry?
We can't hear you.
Can anybody else hear me?
Yeah, Anjali, go.
Yeah.
I think your connection is down.
Your voice is breaking.
Anjali, okay, fine. Let me have this. You can sort the issue you are having. So the question is 36-year-old woman presented with back pain and fever. The findings are as follows. It was a right-sided back pain. Sorry, the spelling for pain. It was onset was the last night. It was associated with nausea and vomiting, dysuria, no increase in frequency or urgency. Reports fever to 101 °F at home. The patient had a history of migraine and was on sumatriptan. The family and the social history, she was sexually monogamous, doesn't use protection, denies tobacco use, drug use. On physical examination, the vitals, the temperature was 100.6 °F, heart rate was 101, the BP was 157/87, and acutely distressed, lying in bed. The serious examination was she was tachycardic, regular without murmurs, no pulsatile mass, right costovertebral angle tenderness, no suprapubic tenderness, minimal spinal tenderness, no inguinal lymphadenopathy was there. Next slide, Mamansa. On the lab examinations, bun creatinine was 25, 1.1. Liver enzymes were normal. Lactate was 2. WBC was 12.2. Neutrophil predominant. Platelets were 152. On urinary microscopy, 100 proteins, moderate blood, no nitrites, no leukoesterase, 35 RBCs, 6 WBCs. LDH was 782. What is the diagnosis?
The diagnosis is pyelonephritis.
It's not pyelonephritis. How will you explain the LDH levels in pyelonephritis? So guys, your time is up. Since there is no bounce in this round or passing, can we have the answer?
Hello, sir. Answer is renal infarction.
Actually, you got it after the time was ended, so we can't give you this. So the answer was renal infarct. Pyelonephritis were a very close DD for this. Can we have the next question? Back. Can we have the back? Can we, Mansa, can we have it on the main page again?
हेलो या हेमेटोलॉजी का तो अगला ही है ना सत्यम?
Oh,
We have to
sorry, my
take it
bad.
to the
Hematology.
next.
Now we have the second question as well. So can I have Akshay now?
A 71-year-old man with abdominal pain and fullness presented to the OPD. Findings: 6 weeks of abdominal fullness and lower abdominal pain. Reports early satiety with 12-pound weight loss. Denies nausea, vomiting, and diarrhea. Denies any constitutional symptoms. Medical history: CLL diagnosed 4 years ago and has been on ibrutinib since diagnosis. Physical exam: afebrile with reassuring vital signs. No cervical, axillary, or inguinal lymphadenopathy noted. Abdominal firmness throughout the lower abdomen. No hepatosplenomegaly appreciated. Cardiovascular exam and pulmonary exam unremarkable. CBC examination: WBC 13800, 73% lymphocytes, hemoglobin 10.7 gram per deciliter, and platelets at 1,59,000. BPM within normal limit, LFTs within normal limit, LHD 439, which is elevated, urinalysis unremarkable, CT abdomen pelvis, diffuse abdominal lymphadenopathy with retroperitoneal conglomerate measuring 19.3 by 7.2 centimeter. What is the diagnosis?
Your time has started. I'm afraid the time is up.
Sir, the answer is acute mesenteric lymphadenitis as a complication of CLL.
No, it's not acute mesenteric lymphadenopathy. Can we have the answer, Akshay? So this was a case of CLL, which was
CLL.
a ritual transformation. So team F gets a +0 in this round. Can we have now team A choose its pair of subjects?
Two.
Mansa, can we have click on 2? Yeah. Can we have the next slide? Over to you, Anjali.
Hello, can all of you hear me?
Yeah.
Okay, so a 39-year-old male presented with progressive swelling of the body and constipation for 1 week. His mother gives a history of poor height gain and mental retardation since the age of 7 years. His BMI was 35. On neurological examination, he was mentally retarded. He had proximal upper and lower limb muscle weakness, power 4/5, and generalized hyporeflexia. Previous examinations showed sinus bradycardia, that is 58 beats per minute, with BP of 130/80 mmHg. What's the diagnosis?
How much time do we have?
60 seconds for this question.
50 seconds.
60.
Okay. Gastrocnemius myopathy, Miyoshi. Hello, gastrocnemius myopathy. Hello. बोल तो दिया gastrocnemius myopathy. Hello. तू बोल दे.
Hello.
हाँ बोल.
Yes, can you hear us?
Hello.
Yeah.
Hello.
Can you hear us?
Yeah, actually, the problem was from our side. We were not able to connect with you guys.
Is the answer is the gastrocnemius myopathy, Miyoshi type.
So we are looking for a specific name of the syndrome.
Miyoshi myopathy.
No, it's not Miyoshi myopathy.
एक सेकंड. Hoffman myopathy.
Yes, that's the correct answer.
Yes.
10 to team A. Can we have the next question for the ENT one, please?
Okay. So the question for ENT: 22-year-old female patient reported to her clinic and complained of pain in both sides of her face and neck for 1 year. The pain was spontaneous in nature, its intensity was dull to moderate, and it was of intermittent nature. The pain aggravated while opening the mouth or moving the head and neck from side to side. She also experienced pain during swallowing, with an associated foreign body sensation in the throat. She underwent surgical removal of impacted teeth 1 year before the same complaint. However, she did not have any relief from the symptoms. No tenderness was elicited in the temporomandibular joints during the mandibular movements. On an intraoral examination, the patient experienced extreme tenderness on palpating the right tonsillar fossa. Next slide. Radiological investigation showed
Eagle
this.
syndrome.
What is the diagnosis?
Eagle syndrome, glossopharyngeal neuralgia.
It's correct.
Yes,
Bang
that's the
on,
correct
that's
answer. So plus 20 for team A in this round. Also, one more thing. Actually, we were not sure on that. You can only answer once. We are giving team A plus 10 for Hoffman, although they answered gastrocnemius. But now from now on, you have to just only once. The next answer won't be considered. Can we have team B now? Because we updated the marks for FLT, so it will go B. Can we have team E now? My bad. Team E. Choose their pair.
We would like to take the first one, pediatrics and ophthalmology.
Okay. For pediatrics.
Can we proceed to the question? Okay.
Yes, please.
A term newborn on day 1 while doing routine examination was noted to have tachycardia, jitteriness, and diarrhea. An ECG was taken which showed multiple atrial ectopics. Propranolol and oxygen were used to treat high output cardiac failure and transient persistent pulmonary hypertension. There was no cyanosis, there was no oligemia or plethora on chest X-ray, but by a few days the ectopic subsided by itself. The child was born to a G3P2L2 woman, a resident of Leh, who was otherwise healthy with no obstetric complication. On further inquiry, she says that the pregnancy helps her survive the cold Leh winters. What is the diagnosis and what investigation should have been performed in the case? Your time starts now. Guys, your time is running. Can I have an answer now? Team E. Team E, can we have a response? I guess we are not able to connect. Team E, can we have a response?
Multiple atrial ectopics.
No, it's not multiple atrial ectopics. Can we have the answer, Akshay? Mimamsa, can we have the answer?
Yeah, we can have the answer.
So the answer is neonatal thyrotoxicosis due to maternal Graves syndrome, neonatal Graves syndrome, the stimulating TSH or antibodies crossing the placenta. Can we have your next? So you are ready for the next question?
Yes.
Guys, the atrial ectopic thing was already mentioned in the question, and I
Yeah.
specifically mentioned that they were remitting on their own. So it's characteristic presentation of neonatal thyrotoxicosis in which the mother was having Graves. So can we move on to the next question?
Yeah.
Okay.
So the question for ophthalmology is, a 7-year-old girl of South Asian origin was referred for evaluation of congenital nyctalopia. Fundus examination revealed widespread golden discoloration and peripheral RPE mottling, as shown in figure A, which becomes normal after prolonged dark adaptation of 3 to 4 hours, as illustrated in figure B. Fundus autofluorescence and fundus fluorescence angiography imaging was normal. Diagnosis and the associated phenomenon.
Team, your time starts now. And it's advised if you answer within the time limit.
Hello.
Yeah.
Is it Oguchi disease? And the phenomenon is Mizuo Nakamura phenomenon.
Which phenomena?
Mizuo Nakamura.
It's
Mizuo.
correct. It's
Yeah,
correct.
it's the correct
Oguchi
answer.
disease.
Plus 10 to team E for their correct answer for ophthalmology. It's Oguchi disease and it's the Mizu phenomenon. So now after that, can we have team B? Because we updated the marks for Felty syndrome. Can we have team B choose their round?
Yeah. What are left?
Team B 1, 2, and 3 has been 1, 2, and 3 has been selected.
Yeah,
We have 4, 5, 6 left.
Number 4.
So the team B is going with number 4.
Are you guys ready for the question?
Yeah.
So we have orthopedics and acid-base disorders. The question for orthopedics is 10-year-old boy has atraumatic progressive right knee pain for 2 months. He denies fevers or mechanical knee symptoms. His examination is completely normal and symmetric to his left knee. Radiographs of the right knee demonstrates open growth plates and a well-circumcised 1:1 area of sclerotic femoral epiphysis. MRI is shown in image A. What is the diagnosis and the initial treatment for the finding? Your time starts now.
I am going with osteochondritis dissecans.
Yeah, it's the correct diagnosis. Can we have the treatment?
Initial treatment is having a rest, avoid stress, more of physical therapy, stretching.
Yeah, that's right.
That's correct.
Just out of curiosity, which is one treatment which is very peculiar to this condition? You won't be marked on this.
Is it like knee immobilization?
Yeah, that's right. Actually, I just wanted oats to be the answer for the the specific treatment one. But you get a plus 10 for this question.
Yeah.
Nevertheless.
So team B gets a plus 10 for orthopedics. Now can we have their question for hematology for acid-base disorders? Akshay?
Yeah. Paramedics deliver a 27-year-old patient whom they found on the pavement accidentally falling from the second-story window. Am I audible?
Yeah, Akshay, you're audible.
The patient had an initial heart rate of 134, blood pressure 86/52, and shallow respiratory rate of 20. Two 14-gauge IVs were placed and 2 liters of lactated ringer solution were being infused during transport. Arrival, the patient remains unresponsive with clear equal heart rate of 138, blood pressure of 88/56, absent radial pulses. multiple contusions and abrasions along the right lower lateral chest and abdominal wall and right hip with ecchymosis in the right groin and perineum. Last exam positive and stable. 14 units of IRBC, 12 units of plasma, and 10 units of blood transfusion of patient. All the results were as expected, but the ABG of the patient was not what expected to be and was in fact the opposite. What are the what are the two history examination points?
Akshay. Actually, Akshay is breaking. After the blood transfusion, the doctor ordered the reports of the patient, ABG, after resuscitative measures, and got a metabolic acidosis, which the doctor was not expecting. So, what was the doctor expecting on his ABG and why? What is one reason of this current ABG findings? Can we have team B? Your time starts now. Can we have the answer? Your time is almost up. Can we have an answer?
The reason for metabolic acidosis is massive blood transfusion where citrate causes high anion gap metabolic acidosis.
Actually, it's not the right answer. You got it a bit opposite. So the doctor actually got the metabolic acidosis in the question. You got, I can guess you, I will give you +10 for this. Can you, actually no, can you again frame the answer a bit right? You said citrate causes metabolic acidosis, no?
Yeah.
No, the question is,
Akshay, wait, wait. So it's not the correct answer. So the doctor was, so the correct answer is?
Metabolic alkalosis.
No, you actually have given the answer for metabolic acidosis. Why metabolic alkalosis?
Citrate metabolism.
Citrate metabolism?
It is a weak acid.
So I can't actually give you marks for this because you had said metabolic acidosis earlier because of citrate. So the correct answer for this, the doctor was actually expecting metabolic alkalosis because it's one of the most common complication of massive blood transfusion because of citrate metabolism generating more HCO3 negative. But in this case, we are looking for some conditions, for example, signs and symptoms of liver failure, because in that case, the citrus won't be metabolized and we are getting a metabolic acidosis instead. So the answer is metabolic acidosis because of citrate producing HCO3 negative, and his current ABG was because of liver failure. Can we go to the main? Now we have done with both the questions.
For citrate, I can't get marks.
No, actually, you first said citrate is for metabolic acidosis, but actually it was for metabolic alkalosis, so we won't be giving you marks for this. Anyway, it was a good try. Can we go to the main slides, please?
Yeah, just give me a minute. I think there's some issue with the hyperlink. I'm
I'm
stopping
just asking for just to clear my doubt. Would you accept hypotension leading to lactic acidosis as a cause of metabolic acidosis, just for academic?
Yes, sir. We would have also expected hypotension causing to that lactic acidosis. Also, hypothermia would have been one of the another reason for causing metabolic acidosis in this case.
Thank you.
Yeah, so we can continue.
Can we have team C choose their option? Team C.
We'll take option 6.
Okay, option 6 for team C.
Should I move on to the question? Yeah.
Video diagnosis. Team C, can we move to the question? So the question here is, on May 2012, a 40-year-old Caucasian woman, Gravida 3, Para 2, was admitted to the emergency obstetric of Santo Bambino Hospital for severe acute abdominal pain, bilious vomiting, closed bowel, feces, and gas for the last 24 hours. In her previous pregnancy, at 10 weeks of gestation, she experienced bleeding with pain, and subsequently a procedure was done. The ultrasound showed normal endometrium, thickness of 7 millimeter, and ovaries. No free fluid in the pouch of Douglas was seen. What is the diagnosis? A laparoscopy was performed and the findings are shown below. What is the diagnosis and what findings would you expect on a PV examination in this patient? The time starts now.
So it's an ruptured ectopic pregnancy in the abdomen, which has now progressed to like adhesive intestinal obstruction, and the PV finding we'll find is like we'll find a frozen pelvis, like all it will be like immobilized. We cannot elicit mobility of the adnexa.
Oh, no, that's wrong. See, the idea was that when this female had bleeding at 10 weeks gestation, at that time she had incomplete abortion, following which curettage was done. So this is syndrome, which is presenting this way. This is a bowel loop, which is herniated through the broad ligament.
So this is the Allen-Master syndrome, which was because post-curettage.
Can we move on to the next question? Team C.
Yes, you can move.
Okay.
A 27-year-old Chinese lady presents to the OPD with sudden onset left-sided hemiparesis, ataxia, aphasia, and agitation. Her MRI scans are shown below. She had no coryza, fever, headache. Her C
I guess Akshay is not clear. So I guess you have read the question and I would like to start your time. Team C.
Is it Bailey-Saccharius procynosis infection?
I'm afraid it's not. Yeah, so the answer to this question is Bellow's concentric sclerosis, as you can see on the MRI. It's a classic variant of multiple sclerosis, which is typically negative for oligoclonal bands and also for aquaporin 4. So that rule outs NMO as well.
Team C gets a +0 for both their questions. Now we move on to Team D, who has the fifth hyperlink left. So Mansa, can we have the fifth one?
Yeah. So it's Derma and Onco. Is the team ready?
We're ready.
Okay.
A 15-year-old white adolescent present to the dermatological clinic with an asymptomatic rash on his upper back that has persisted for 4 months. Physical examination reveals hyperpigmented scaly papules coalescing into confluent plaques with peripheral reticulated and large dermal papillae. The boy is overweight but has no history of any other medical condition. What is the likely diagnosis for this condition? So your time has started. Team D, can I have an answer?
Is this pityriasis rosea?
No, it's not pityriasis rosea. Once again, we have the answer. It's confluent and reticulated papillomatosis, CARP. Can we have the next question?
A 27-year-old female who had suffered from recurrent fractures for 17 years, visual decline for 12 years, and a gradually rounded face with distended abdomen and purple stria for 7 years, was admitted to our hospital. For 17 years, she has often suffered from various fractures involving almost every part of the body after mild activity. She now presents with paroxysmal nocturnal dyspnea, cough, pink-colored frothy sputum with ejection fraction 45% and an early diastolic sound. She has extensive spotty pigmentation. She had undergone total thyroidectomy 7 years back and bilateral adrenalectomy 5 years back. What is the diagnosis and what is the underlying defect? Your time starts now.
Can you explain what you mean by where is the underlying defect? Are you talking about an anatomical defect or a like something else, genetic or something?
So that would be a giveaway to this question.
So can we have an answer? Team D.
Is it Nelson syndrome?
No, sir. Sir, it's actually cardiac complex with there's a long history of Cushing syndrome, which indicates PPNAD in the adrenal glands. And also there's an early diastolic sound with reduced ejection fraction, which is pointing towards atrial myxoma. So it was cardiac complex and we were expecting PRKAR1 mutation.
So we finally came to the end of this long round. Can we have the scores?
So team A is leading with 110, team B 50, C 40, D 40, E 60, and F 70.
So now we will move on to the fourth round of our quiz, and I would have Shubham and Sukrit as the quiz masters for this round, and they will explain you the rules as well. Or you guys want a 5 or 10 minute break between the rounds?
Please continue.
Hello? Hello, I'm audible?
Yeah, Shubham, you're audible.
Hello, good evening. So we will start with the round 4 right away for the introduction. And I have Sukrit with me, who will be helping and will be alternately orating the questions. So, Mimanta, next slide.
Yeah.
So, multi-step, as the name of the round, there will be multiple steps. Each team will be providing with a 3 steps, and the answer will be same, but the question would have some part of it in the different steps. So what you have to do is actually you have to answer in any particular step, but and the answer is diagnosis is same. But what you have to do is if you would answer it initially in the step 1, then you will get 40 marks, and if you had answered in the step 2, you will get 20 marks, and if in step 3 you will get 10 marks. So the diagnosis will be same, but based upon how much clue you have to require to make the diagnosis, the marks will be different. So I will be reading it again. Each team will be provided with 3 steps in a question, and the first step will be initial presentation of the patient with some details omitted, and the team will be asked to diagnose. If you can't guess the answer, then we will be providing with 2 steps and then the step 3. I cleared the scoring system, 40 plus 20 and plus 10. You will only get 1 chance to see the answer, and if a wrong diagnosis is made at any step, the team won't get any marks, no negative marking.
Also, the time for each step will be decreased. In this step 1, you will be getting 45 seconds after the quiz master has stopped reading the question. For the next, you will get 30 seconds, and for the last, you will get 15 seconds to make the diagnosis.
And to confirm, would they be allowed to go back to the question?
No, they won't be allowed to go back to the previous step.
Okay. I think rules are clear. Any doubt? Okay, I hope not. Mimanta, first question, and the first question is for team D.
Excuse me, so only one answer will be accepted, not one at each step.
No, the diagnosis is 1. The final answer is 1. We have some steps. For example, the first have a clinical presentation. The second step will have some investigations, and the final will have an image or some investigation, other things. If you guess the diagnosis at the first step itself, you'll give a plus 40. If you are not able to make the diagnosis at that point, you can take help of the next clue we are giving to you. If you guess it that time, you'll get a plus 20.
So we can guess at every step.
You can guess it at any step, not at every step, only one. If you guess
okay.
one,
fine.
You won't be getting the next steps.
Okay.
So you need to be careful at step 1.
Can we start?
Yeah. First question is for team D. So
team D, right?
Are they ready? Yeah, team D.
We're ready.
Okay.
So, a 17-year-old patient presented with a 10 days history of cough, sore throat on 27th April 2020. He also reported with a fever of 39.1 degrees Celsius from past 5 days. Physical examination revealed dysplegia, tachypnea, bilateral crackles in the lower segment of the lung. There was no hepatosplenomegaly, but there was a palpable splenomegaly. He had gross cervical lymphadenopathy with submandibular nodes that more than 10 centimeters in diameter. BP was found to be 112 by 64, heart rate of 81 per minute, and SpO2 of 84%. Temperature was found to be 39.4 degrees Celsius in examination, and investigation revealed hypernatremia, hypocalcemia, elevated alanine transaminase, aminotransferase, and lactate and C-reactive protein. Hemoglobin was found to be 8 gram%, and WBC to be 2000. Platelet was found to be 1.5 lakh, and LDH 586 units per liter. Reticulocytes were found to be 13%, and CRP increased with D-dimers of 3759 nanogram per ml. And fibrinogen was also found seen and 1.43 gram per liter. Next slide, please.
Starts now.
Can we answer at
Yes,
this?
you can answer.
Sir, if you get a wrong at this step, you won't be getting the next steps.
Okay, I think we'll still answer. Okay. Is this COVID-19 cytokine storm syndrome?
No, yes, sir, it's the COVID-19 cytokine syndrome. Team D gets a plus 40. So it was in the next investigation. Shubham, can we have step 2?
For the examination, the ferritin was found to be.
So on Shubham, tell.
Ferritin was found to be 8197 microgram per liter, and triglyceride was found to be 450 microgram per deciliter. On further investigation, revealed HIV negative, the serum analysis of HIV, HP, hepatitis B, hepatitis C, and toxoplasma seen to be negative, and EBV and CMV, IgG were found to be positive, but IgM and IPCR were negative. Serum immunoglobulins and electrophoresis were normal, and blood cultures were negative. On admission, chest X-ray was done, and seasonal respiratory viral PCR panel was also done. But for all the findings were found to be negative.
On the next step, we also showed the figure that was showing hemophagocytic lymphohistiocytosis. Can we have the answer? So it was macrophage activation syndrome, cytokine storm syndrome, or the HLH syndrome. So now we have direct for team E.
But they answered COVID-19 cytokine storm, right?
Actually, we considered it late, but both these syndromes were fitting. So we initially we had HLH, but we also considered cytokine syndrome in this. Shubham, can we have next?
So next team is team E. Is team E ready?
Team E.
Yes, we are ready.
Okay, ma'am, can we have the next slide? So your step 1 is a 41-year-old woman with tuberculous cervical lymphadenitis had been treated with first-line anti-TB drugs. 21 days after starting treatment, she developed fever of over 38.5 degrees Celsius, a non-pruritic maculopapular rash, myalgia, and lethargy. She also complained of looking more red than usual. She had no other medical history and was not on any regular medication, prescribed, herbal, or over-the-counter. On examination, she had icterus and also the liver was palpable in the patient. The pre-existing enlarged lymph node in her cervical chain secondary to tuberculous adenitis was palpable. At presentation, the reports of the patient were misplaced except one report. PCR of plasma was performed to detect EBV, cytomegalovirus, and HHV6. HHV6 came back positive. Additional serological investigation showed no evidence of acute infections with Hep A, Hep B, Hep C, Hep E, EBV, or CMV. Your time starts now.
We want second step, please.
Okay, ma'am, can we have the second step? So 4 days after discontinuing TB medication, the CRP reduced to 20 mg per liter, bilirubin 8 micromole per liter, ALT 427 IU per liter, AST 643 IU per liter, alkaline phosphatase was 149, gamma glutamyl transpeptidase was 501, and albumin was 3.9 gram per liter.
Your time starts now, 30 seconds.
Hello.
Yes.
Yeah, I'm coming up with an answer. Is it DRESS, drug reaction with eosinophilia and systemic symptoms?
Yes, it's the DRESS syndrome.
So team E gets plus 20 as they guessed on second step.
Can we go to team F now? Team F ready? Team F?
Yes.
Okay. First slide. Hemanta. So step 1, a 4-year-old girl was admitted to hospital because of steatorrhea and short stature. Her height was found to be 83.7 centimeter with weight of 11.5 kilogram. Head circumference was 48 centimeter and the body proportion were appropriate. The patient was born at 36 weeks and 4 days. There was no problem during her perinatal period. Early growth and development were normal. However, at the age of about 3 months, she presented with frequent purulent otitis media and pneumonia. After teething and dental caries developed early and she required frequent dental treatment. She also had bony abnormalities in her lower limb and fingers that found, for example, syndactyly. During late infancy, steatorrhea and foul odor developed, and amount of stool was also found to be very large. There are no signs of any obstruction in the GIT was noted. The patient had performed normal active physical and cognitive activities for age. The family history was negative for similar clinical problems. The vital signs were normal for age, and she had angular stomatitis. And examination of the teeth revealed many dental caries and crown prosthesis. The liver and spleen were found to be palpated, but not palpated, and examination of the musculoskeletal system and nervous system were found in normal limits. You are not audible. Please unmute yourself.
Yes, you're audible. Like when it's 5 seconds before, can you just tell for 45 seconds?
The answer is Schwackman-Diamond syndrome.
Yes, you are right. Team F got 40 marks. So the step 2 shows. Sukrit?
Sir, this is the same question, third question on the step 2.
Should I move on to the answer slide?
Yes, ma'am, answer. They have given the right answer.
Okay.
So step 2 showed the lab values of the Schaumann diamond, and the step 3 was a negative test for the
sweat chloride test.
The negative sweat chloride test, which was done using pilocarpine, excluding cystic fibrosis.
So team E gets plus 40. Team F gets plus 40. Now team A. Team A, are you ready?
Yes.
Can we have the question? The first step. Okay, the first step is a 33-year-old female with history of depression was brought in by the paramedics after an apparent suicide attempt. The patient was unresponsive and pulseless. She was in cardiopulmonary arrest and hemodynamic collapse. She was intubated and placed on mechanical ventilation. Her sister says that she took some drugs. Ma'am, this slide changes.
Yeah, it's that.
Her sister says that she took some drugs following which she had drowsiness, dry eyes, difficulty swallowing, seizures before she ultimately collapsed. The skin was flushed and dry, both at the same time. What treatment should have been given instead of lignocaine? Your time starts now.
Guys, please kindly ignore the last line. It's a fault on our part. Just concentrate on treatment part.
Physostigmine.
No, what's your diagnosis for this question?
Atropine poisoning.
No, it's not atropine poisoning. Actually, the key feature here is that the skin was flushed and it was dry at the same time. We have anticholinergic features, but at the same time, we also have histaminic features, antihistaminic features. So this is TCA toxicity. Step 2 would have shown that this patient was having worsened. So our question was, what treatment should have been given instead of phenytoin? So bicarb was the answer. And ECG shows characteristically positive R waves in case of AVR leads, which is not seen otherwise.
Excuse me, can you repeat what the finding in ECG is? Couldn't catch it.
Yes, sir, sure. So there are positive R waves in case of AVR leads, in case of TCA toxicity. Hello, Harsh sir.
Yeah, sorry. Thank you. Got it. Thanks a lot.
Guys, move on to the next question for Team B.
So, next question for Team B. Team B ready?
Yes.
Himansha? So, step 1. A 1-week-old unit presents with bloating, abdominal distension, malabsorption, steatorrhea, and hepatosplenomegaly. The child has persistent fever, hypotonia, jaundice, and failure to thrive. Liver biopsy findings shown a bright yellow color in large liver-laden hepatocytes and copper cells. Microvesical, macrovesicular cirrhosis both were found, and fibrosis and cirrhosis were also found. So what's your diagnosis?
Your time starts now.
The idea, guy. Shall I say? Hello?
Hello, yeah, so you want to answer or you want the next clue?
I want to answer.
Okay,
Hello?
please go ahead. Yeah.
Is it lysosomal acid lipase deficiency, cholesterol ester storage disease?
Yes, you are right.
That's absolutely right.
Or also called Baldwin's disease.
Yeah, so step 2 was showing Sibyl lipase alpha, which is the recombinant enzyme that we use for this condition. And also step 3 was showing the classical adrenal gland calcification, which we get in Wallmans. So bang on, Team B.
Okay, so next question is for Team C. Team C, are you ready?
Yes, you can proceed.
Ma'am, next slide, please. Okay, so step 1 is a 35-year-old female presented to the ER following a syncopal episode. She noted 1 to 2 minutes of palpitations prior to syncope. Denies prior palpitations or syncope in the past. Denied chest pain or shortness of breath. She denied known past medical history. She takes no medications except an over-the-counter multivitamin. She complained of swelling in her feet. She denies any prior surgeries and she denies drug or alcohol use. Her paternal uncle had an unexplained death at age 42. Physical exam and lab shows vital signs, heart rate 75, BP 110 by 75, 95% O2 on room air, temperature 37.2 degrees Celsius. Physical examination confirms the pedal edema and shows presence of diffuse keratoderma in palms and soles. CBC, BMP, and thyroid function tests all WNL. Your time starts now. Please answer.
It's Naxos disease, Naxos syndrome.
Yes, you are right. So the ECG would have shown the epsilon wave seen in Nexus. The V1 is showing that. If we would be able to zoom it. And next slide would have shown the histo of ARVD. So that's fibrofatty change in the myocardium, and usually seen in the right ventricle, hence the right ventricular dilatation and the symptoms. Can we have score of this now? I think everyone has answered right.
Yeah, so team A is at 110, B is at 90, C is at 80, D, E also at 80, and F is at 110 as well.
So Mimamsa and Satyam will be taking the next round. Satyam?
Hi, correction. Shivadeep will be taking the round with Mimamsa. So can we have the next slide? So this is the end of round. Now we have round 5, which is an investigation and treatment round. It is again a pounce and bounce round. So I would advise you to have your phones in your hands. Over to Mimamsa.
Yeah, so in this round, this is the 5th round of the quiz. Specific treatment for the diagnosis, right? Both the things have to be specific. We are not accepting answers like ESR or CRP, or even if you give some blood investigation, please mention what you'll be looking for. Okay, so the pounce window will be open for 30 seconds. Correct answer will be plus 20 on direct and pass. So, yeah, to me, only plus 10 will be accepted.
Excuse me. Third from the last point says the direct. Sorry, fourth from the last one says the direct question can also be pounced. How is that possible?
It's just like the first one, right? In first one, we
Oh, if it's actually
bounced the
something like
questions
team E's
to the
direct
teams who have
question.
not passed. Yeah.
Sorry,
See,
can you
if
repeat
it's
it again?
teamy's direct question, yeah, sure. If it's teamy's direct question and you have pounced, so it will become a direct to team F that way. Just like we've done in previous rounds, it's the same, nothing new.
Okay.
Okay.
So guys, can we move on? This will be a direct for team E.
Yeah, is team E ready?
Yeah, we are ready.
Okay. Yeah, so it's a 54-year-old male, non-smoker, non-alcoholic, who's a known diabetic and there's no history.
Hello? The audio is breaking for you. Hello?
So I guess her audio is breaking. So I'll continue the question.
Okay.
54-year-old male, non-smoker, non-alcoholic, non-diabetic, and hypertensive presented with fever, dry cough, and progressive breathlessness for 1 month. PFT revealed the given flow volume curve. There was no history suggestive of a connective tissue disorder. The patient had a chronic occupational exposure to concrete and limestone, two known sources of silica dust. BAL showed pass positive material, and CT had the following finding in the next slide. The same patient returns 15 days later, this time with cough, with sputum production, fever, seizures, altered mental status, and visual deficits. There were no signs of neck stiffness. What do you think is responsible for the second presentation? List the diagnostic modality and treatment modality for the second presentation of the patient. Can we have the next slide showing the CT scan and the
Yeah, so the gray curve is
yeah,
normal, and the red curve is what is expected, is what is being seen in this patient.
the Pounce window is now open for the next 30 seconds. Shwani. The Pounce window close in 3. So we have a Pounce from team A and we have a Pounce from team A. Yeah. So now can we have the direct answer for team E? Actually, wait a minute. The team A is still writing the answer. Answer?
Yeah. 1 second, there's a fault on my part. Yeah. So team E has answered, or hello?
It's for direct team E.
Yeah.
Team
Is it tuberculosis? And the gold standard test is antibody detection. Drug of choice is the first line TB drugs.
No, it's not. Actually, what I'm asking in this question is what is the reason for the second presentation? And in the second presentation, which investigation would you like to go ahead with first and the treatment?
TB meningitis,
No, I'm afraid it's not.
Can we move on to the past question to team C?
Team F.
Team F.
Team F.
The diagnostic modality for the second presentation is you can use culture or CB-NAT or a sputum smear for TB, and treatment modality is HRZT. And what do you think is the cause for this is silica tuberculosis, and the primary diagnosis was pulmonary alveolar proteinosis due to acute silicosis.
I think we'll move on to team C. No, team B. Team B hasn't pounced, right? So team B gets the opportunity to answer.
Hello.
Yeah.
Is it amyloblastoma following silicosis?
No, it's not. Team Team C.
So the
Team
second
C.
presentation is the tuberculoma, and the diagnostic modality will be MRI with MR spectroscopy, and treatment modality will be ATT. And if it does not regress, then we have to go for surgical drainage if it's feasible.
The answer, or maybe are we left with somebody?
Team D is left.
Yeah, team D.
Diagnostic modality, lumbar puncture, and treatment, perhaps brought with antibiotics.
So please be specific. What are we looking for in lumbar puncture or in antibiotics?
We're looking for bacterial encephalitis. I think pulmonary alveolar proteinosis has predisposed towards an secondary infection, which has gone to the brain. So bacterial picture in the lumbar puncture, increased protein, low glucose, and gram stain in cultures with organisms.
So actually, what I was expecting in this question is that it's pulmonary alveolar proteinosis, no doubt, but it was leading to secondary nocardiosis. So there was a nocardial abscess right in the occipital lobe, which was leading to visual defects and altered mental status.
But that is seen only in
And
primary
the idea was that
pulmonary.
PAP impairs the macrophage phagocytosis mechanism. I don't think so. In any case, if it's PAP, in any case, macrophage function would be impaired, right? So that is what is predisposing to nocardiosis. So we were
Silicosis
expecting
itself also क्या कहते हैं, inhibits the alveolar macrophage function ना. तो
Yeah,
मतलब
totally
like
agree.
is it important that it is nocardia only and not because of TB? Because मतलब I'm not, if like उसमें भी तो हो ही सकता है ना, मतलब TB या nocardia.
See, all the macrophages will be like inhibited, right? So any infection with like tuberculosis also can present like this. Not only
Yeah, I
nocardia.
agree. Yeah, I agree to this. It was a failure on my part, maybe to make it less specific. So I think we'll give it to all those who have answered it as silicotuberculosis.
Can you clarify the marks each team gets?
Yeah, yeah.
First answer.
Bhavya. Hello, Bhavya. Can you clear up the marks for this?
Hello, am I audible?
Hello, wait a minute, Bhavya. Just wait a minute.
Okay.
So it was a confusion on our part, and it was our problem. So we had decided to give marks to team A for the pounds. They get plus 30, and we're giving marks only to team E. They get plus 20 because they gave the correct answer on the first go. We are really sorry for the confusion and the incompetency. Can we move on to the next question, or anyone else has any doubt? We are giving it plus 20 to team E because they have the direct, and team A because they pounced.
Hello. They have like team E answered it partially correct, not full. I think they answered investigation of choice as some antibody test.
Antibody testing.
I don't know how it is. I think it's banned also.
I guess they answered CBNAT only, I guess.
They didn't have silica tuberculosis, right? That's what you expected.
Okay, just a minute.
You better cancel this question. That will be better, I think.
silicotuberculosis is fitting in everything. So why the question should be cancelled?
Okay, so we won't be canceling the marks for the, we won't be canceling this round as per, since it was a incompetence on our part. What we'll be doing, we'll be canceling the direct answer as we did in the first round in the first question. We'll be giving marks to team A for their pounds, and we won't be giving many marks for direct. Can we go to the next question?
Sorry, I didn't understand. Can you repeat it again?
Actually, since it was a confusion and we are not sure which team answered the complete answer whole, we'll be giving marks for the pounds.
You guys were hearing, right? You don't know which team answered first. Like what they answered, you don't remember.
No, but
You guys
we
were
know who
hearing, right?
pounced.
What?
Yeah, you know who pounced, right? The direct teams also should get the mark, or the past teams also should get the mark. Whoever answered. If you're giving for pounds, you cannot give for one team and not give.
If you're not, I honestly think you should cancel the question. But if you're not canceling it, then just give marks to the first team that answered tuberculosis, because then the pass would have been redundant if you're accepting tuberculosis.
But
Exactly.
sir, so we'll be giving marks to team E because they answered silicotuberculosis.
Honestly, I think this can be any infection, so I don't think you should be entertaining this question. But anyway, that's your call.
சொல்றேன்
Guys, we are really sorry. We'll be canceling this question. And team A, you'll be getting your direct question towards the end of the quiz. I hope that's fine.
Yeah.
What you said? I'm sorry, we couldn't catch it.
So we are planning to cancel this question. And so team E will be getting their direct question towards the end of the quiz. I hope that's fine.
That question will also be on pounds and like the same format as this, right?
Yeah. Same format, sir.
Okay, we are fine with that.
Yeah, we are really sorry. The thing is that we are all learning in this process, and it was, anyways, it was a fault on my part. Yeah. So next question, direct for team F. A 29-year-old right-handed male had experienced recurrent seizures for past 4 years. The patient's seizures began with loss of consciousness, followed for 1 minute, followed by movements such as chewing, smacking of the lips, and progressing to flexing of the limbs, shaking and stiffening. Seizures occurred with aura and lasted for several seconds to minutes. Initially, the patient's seizures only occurred 3 to 4 times a year, but this frequency gradually increased to nearly once a week, and they are now intractable with medications. The patient has a history of febrile convulsions. There is no history of meningitis, gait abnormalities, or any developmental delay. The patient had no history of any other medical condition, and the findings of neurological examinations were also normal. So, what is the gold standard investigation and the treatment of choice for this condition? Team F. The pounds window is open.
The pounds window is now closed. Team A, Team D, Team C, and Team F has pounced for this question. So we have Team E answer this question. Team B answer this question right now.
It's mesial temporal lobe epilepsy. The gold standard investigation is EEG with MRI, and the treatment of choice is amygdalohippocamperectomy.
Can you please be a bit more specific with your investigation? It's a gold standard investigation that I'm asking.
It's ISCOM like that. MRS. Hello.
Hello, yeah.
MR spectroscopy.
I'm afraid that's not the right answer, which I was looking for. What was the treatment of choice that you told?
We pass on to
Amygdalohippocamperectomy.
team. We pass it on to the next team.
The treatment
So,
option is right.
team-
No. Amygdalohippocamperectomy.
Yeah, the treatment option.
But we won't be giving marks for part. There are no part points in this round.
Given 5 points for.
Is right. I think we'll give them plus 10, as we had.
You said
they
there
were.
are 10 and 10 for each.
It was like we'll give them a plus 10, I think.
Fine.
Yeah, so the gold standard investigation in this case is a sphenoid sinus EEG. The treatment is temporal lobectomy. We are accepting, and in fact, it's a better answer, hippocampectomy. And the diagnosis was mesial temporal lobe epilepsy. So, Bhavya, can we have the marks for this round? For this question, rather.
Excuse me, will the investigation oblique coronal sequence of MRI will be considered?
No, we are just.
Because this is gold standard to measure the hippocampal volume. So specifically in mesial temporal lobe epilepsy, it is used. The oblique coronal
If you can
sequence.
cite an evidence regarding that, I might consider, because I've read it as sphenoid sinus EEG. So
Yeah,
if you can
that is
cite an
also
evidence.
correct, but oblique coronal sequence is specifically reserved for hippocampal volume measurement.
If you can provide me with an evidence over the group, I will consider that.
It is taught us in class by Dr. Sumer sir.
Yeah. But in any case, we are not considering just MRI. That has to
No,
be clear.
oblique
So
coronal
any
MRI,
team
not
which has
MRI.
answered it as yeah, I agree. Yours is fine, but I think Team D has given it as MRI, and yeah, that's it. So we are not accepting it, and in fact, functional MRI also. So Team C gets a plus 30 in this round, in this question, and Team F gets a plus 10.
No, team F actually pounced on this question and they get a minus 10 for the wrong pounds.
Okay.
And also team B gets a minus 10.
And we also pounced ours.
Team A, for now, we are considering a minus 10 for the coronal MRI. If you can show us the gold standard as coronal, as the oblique MRI, oblique coronal MRI, we'll consider it. So this question, we get a
Yeah, it's a plus 30 for team C. And it's a
for A, D.
plus 10 for, yeah.
Plus 10 for I guess team E. So can we clarify one thing? Team B gave the direct answer, right?
Yes, yes.
But you gave it half, so we'll be giving you plus 10.
Yes, yes.
Okay, thank you. Team B gets a plus 10. Can we have the next question?
Yeah, so it's a direct for team A, right? Yeah. So a 10-year-old Saudi girl presented to our endocrinology clinic. She was a product of spontaneous conception in a consanguineous marriage after an uneventful pregnancy at full term with no birth complications. She had a weight of 3.2 kgs and a length of 47 centimeters at birth. On presentation to the clinic, she had a short stature and a weight of body mass index at that time was 15. Her upper segment to lower segment ratio was 1.15:1. Upon examination, she was noted to have a protruded forehead, thin hair, small hands and feet, and a saddle nose. There were no teething defects and there was no loose sclera. She was reported to have reached her developmental milestones at the appropriate ages, but she had an episode of hypoglycemia as a child, and she has two brothers who are short, while the parents have a normal stature. So, what is the investigation and the treatment that should be done in this patient? Team A or direct. And the pounce window is open.
The pounce window is closed. Team A, can we have an answer direct?
Investigation is selective arterial calcium.
Can one of you speak? I guess the voice is not clear.
Hello, can you hear?
Yeah.
The investigation is selective arterial calcium infusion.
Okay.
And the treatment should be surgical removal of the mass, or diazoxide can also be accepted.
What are we expecting in this patient? What is the diagnosis?
It is a nesidioblastosis associated with some syndrome, but I think diagnosis is not important as some syndromic
Okay,
form
can
of
we?
nesidioblastosis.
I'm afraid that's not right. Can we bounce it to the next team? So team E and F had pounced for this question. So we'll pass it on to
I
team
can.
B. Team B.
Diagnosis is Laron syndrome.
Okay.
Investigation of choice is serum GH levels and IGF-1. The treatment is subcutaneous IGF-1.
Yeah, that's right. So team B gets a plus 10. Team F gets a plus 30 for the right answer on pounds.
And team E gets a minus 10 because they had an incomplete answer on the pounds. The treatment was not there.
Yeah. So can we move on to the next question? Team B, it's your direct.
Excuse me, I got both on right light. So I should get 20 points now.
Yeah, you're getting a plus 20.
Okay.
Yeah, you got both right. Oh, sorry, my bad. Yeah. Plus 20. Okay, so
So now we are moving to the next question. This is a direct question for team B. Is team B ready?
Yes.
Mimansa, can we have the next slide? I guess there is some connectivity issue. Mimansa, are you on? I guess this slide is not. Guys, there was a network connectivity. Just give us a couple of minutes.
guys, is the screen visible now? Hello?
It's visible.
Okay. Yeah, so the direct question for Team B. Team B, are you ready?
Yes.
A 16-year-old female with chronic abdominal pain who underwent lap cholecystectomy for cholelithiasis but continued to experience abdominal pain, nausea, and vomiting. Her lab findings were as follows. AST was 831 international units per liter. ALP was 300 international units per liter. Abdominal ultrasound was non-diagnostic. Esophagogastroduodenoscopy showed mild reflux esophagitis and mild chronic Helicobacter pylori negative gastritis. Omeprazole was started, but it did not decrease the frequency and severity of abdominal symptoms. MRCP did not reveal any pathology. Name the gold standard investigation for the diagnosis of the above mentioned condition.
Pounce window is now closed. We have team C and team E pouncing for this question. It's a direct for team B.
Shall I say now?
Team B, you can answer.
It looks like sphincter of OD dysfunction. The investigation of choice is sphincter of OD manometry, and the treatment is Botox injection, endoscopic Botox injection. Hello? Hello?
Just a minute, we have some issue connecting with one of the partners. Just a minute. So we have, so that's the correct, so SOD was the correct answer. We were having a discussion because we forgot to mention the treatment part in this question. So we are omitting it. So team C and E gets a plus 20, plus 30 pounds. And team B gets a plus 20. Can we move on to the next question, AMSA?
Yeah, sure. So it's a direct for team C, right? This time?
Yeah.
Okay. Yeah, so a 6-year-old boy was born to first degree healthy consanguineous Tunisian parents. His family history was unremarkable, and in particular, no sibling or any other relative was affected in the family. Epileptic attacks, which started at the age of 6 months and had ataxia. He presented with psychomotor delay. Walk was acquired at 2 years, language at 4 years, and he also had gait imbalance. Symptoms typically worsened after physical exertion and exercise. Examination showed decreased head circumference, mental retardation, language delay, cerebellar syndrome, and generalized chorea. The brain MRI was normal, and CBC showed decreased hemoglobin, decreased RBCs, and they had a raised RDW. The CSF blood glucose ratio was 0.15, and the CSF lactate levels were also low. Routine blood tests, thyroid test, blood cholesterol, albumin, and AFP were normal. Karyotype was done, and it came out to be normal. So, which investigation should be done in this patient to clinch the diagnosis, and what treatment should be given? Team C, your question. The Pounce window is open.
The Pounce window is closed now. Can we go on to team C answering the question?
The treatment is, I think, vitamin E, and diagnosis will be genetic testing. Maybe I'm not sure.
Sorry, it's not the correct answer. Passes to team D.
Is the treatment to avoid fasting and maintain blood sugar levels. And investigation, I think it's fatty acid pathway synthesis, medium chain क्या था वो acyl carnitine deficiency. What? MCAT deficiency, medium chain acyl.
No, sir, it's not MCAT. Can we move on? Sorry, so that's not the right answer. Can we move on to team E? Team E.
Spinocerebellar ataxia?
No. Team F.
This is GLUT1 deficiency syndrome. Investigation is CSF glucose. We have to CSF glucose is the investigation to cleanse the diagnosis. It will be low.
That we've already done.
It will be low.
Yeah. So what other investigation should be done, which will help you clinch the diagnosis?
One second. Treatment support. See, we have to.
Guys, we can't give more time because you've already told the diagnosis. So it's, we can't give.
We have to do genetic studies to confirm mutation in GLUT1 receptors.
And what's the treatment that you would give in this patient?
Treatment is, the patient cannot metabolize glucose, so you have to give the patient ketones and other we cannot give them glucose, and you have to give other form of treatment which will cross the blood-brain barrier, such as ketones.
Right. So team
ketone
F, yeah, we'll give you a +10 for the treatment part, but your investigation is wrong in this case. So were there any bounces for this?
Shall I try?
I don't think you can, because team F has already answered it. We can't bounce it further. Team A
you
got
can
it wrong.
cleanse the diagnosis by finding, right, by genetic studies. However, you didn't ask anything specific like gold standard investigation of choice, nothing, right? How will you clinch? If I find a mutation in GLUT1 receptor, domain coding for GLUT1 receptor, then it is clinching the diagnosis.
But will you do genetic studies in every case? I mean, there's a better investigation which we can do.
There is nothing what will you do next investigation? What is the first line investigation? Nothing, right? There's no gold standard. Nothing is written in this question also.
I'm sorry, but we can't accept genetic testing in this case. The specific answer which we were looking for was RBC flow cytometry, because RBCs also have GLUT1 receptors. Or the other answer which I would have accepted would have been decreased erythrocyte transport of glucose. We told it right in the beginning. You have to be specific.
Can you please repeat the what you said about the other answer you would have expected, accepted the second investigation?
Yes, sir. Sir, GLUT1 receptors are also present in RBC membrane, apart from blood-brain barrier. So either we can look for decreased transport of glucose in the erythrocytes, or a better answer would have been RBC flow cytometry for GLUT1 receptors. So +10 for team F and -10 for team A.
So now moving to the the next question of this round, it is direct to team D. And it's the last question for the round.
The case of an 11-week-old boy after a full-term normal vaginal delivery with a birth weight of 3.6 kg. This is the case of that boy. The pregnancy was complicated by gestational diabetes mellitus. He presented at the age of 2 months with a history of right lower limb non-pitting edema and chronic diarrhea since birth. The right lower limb edema started soon after birth. It was associated with redness and warmth, and later on the edema became generalized and noticeable on the face and both lower limbs. The diarrhea was up to 6 times per day, loose, non-greasy, with no mucus or blood. There was mild abdominal distension. His feeding and activities were normal. 24-hour stool alpha-1 antitrypsin levels were also raised. The abdomen and both testicles were mildly distended. His lab tests revealed low total serum protein, low serum albumin, low serum calcium, and high ALP. What is the specific investigation the finding, and the treatment for this condition. Team D, you're direct. The Pounce window is open.
The Pounce window is now closed. Since no team has pounced, we got in an orderly way. Team D, can we have the answer?
This is direct to us, right?
Yeah.
Just a second. The investigation is probably endoscopy. Treatment for the condition is high protein diet. Finding would probably be lymphangiectasias. The intestine? Yeah, in intestine.
So you were not clear. Can we have the investigation, the treatment again?
Um, Investigation is endoscopy. Finding being intestinal lymphangiectasias. Treatment being a high protein diet.
Yes, sir. Yeah. Sir, can you be more specific on the treatment of the patient?
Yeah, matlab, like top feeding. I mean, specific how, matlab, like, I don't understand exactly.
Sir, you said high protein and
Calcium supplemented diet. I'm not sure. क्या होगा? High carbohydrate diet.
guys, you have to consider this. So the answer was, so we'll give you the answer for the endoscopy and the diagnosis. It is intestinal lymphangiectasia, and the diagnosis of the patient is done with the help of a endoscopy. The treatment actually I was looking for specifically was a low fat diet and an MCT in the diet along with a high protein and the high protein diet. Himansa, can I have the next slide?
Yeah, sure.
So it was correctly guessed intestinal lymphangiectasia. A fat lowering test with butter is done at night, which is followed by an endoscopy to see white plaques over the mucosa. The treatment is a low fat, high protein diet with MCT oil. So plus 10 to team D. So we have ended with the round 6. Now we are moving on to the last round of the quiz, which is the round 6. Himansa.
Yeah. Okay, so the round 6 is known as Mega Mind. What we have done in this
Hello.
round is that, yeah.
Team E, after the end of this round or the end of the quiz, will be getting their round 5 question.
End of the quiz.
End of the quiz. Okay. Thank you.
Yeah. Okay, so in this round, what we have done is that each team will be getting a set of 3 questions. Those 3 questions have something in common which has to be answered. So let's refer to the marking scheme. Yeah. So each team will be provided with 3 questions, one after the other. If you can't answer the first question, you can definitely skip it and go to the next one. But you cannot come back to the previous question. There is no negative marking for a wrong answer in any of the 3 questions. So it is encouraged that instead of skipping, you just answer all the questions. So again, all the 3 questions have something in common and you have to guess that mega connect. So even after you get the first question, you can try guessing the mega connect. So if you get it correct after the first question, you get a plus 30. If after second question, then a plus 20. If after third for each question, so you can score a maximum of plus 60 in this round. That's how it is.
So Team F, are you ready for the question?
Can we have the scores before?
Yeah,
Yeah,
sure.
sure.
We have scores. Can we have the scores?
At each level, we can go for the Mega Connect, right? Like after the
Yeah,
first
at each
step, we
level,
can
only
go.
one guess. Only one guess.
No, like in the rules, it's written you can guess the Mega Connect even after answering the first question itself.
Yeah, sure. You
But
can go
only
for the
one
connect
chance at each step, right?
at each step only once.
Okay, okay, okay,
No negative marking, so you can openly answer.
okay.
To confirm, we can go for.
Also, what is unique is that once you, yeah, yes, sir.
Go ahead, go ahead.
Yeah, what is unique is that once you give an answer for the first question, we won't be telling you whether you're right or whether you're wrong. So you have to just disclose your answer. We'll be marking you, and in the end of all three questions and the Mega Connect, we shall be disclosing the answers.
So if any one of the answer is right, you will give marks.
Yeah, see, every
Actually, I'll
question has
clear
a
it
plus
once again,
10.
Vimansu.
That's a different thing. Yeah,
I'll
yeah,
clear it
sure.
once again. You'll get question 1. You'll have a answer. We won't tell you the answer is right or wrong. If you have a right answer, we'll give you a plus 10. If you have a wrong, we won't tell you. Fine. Then you'll get the chance to say the Mega Connect if you want to, according to the answer you have given. It can be correct, it can be wrong. Then we'll go to the next step and the next step.
Like if you are correct in the first, after the first question, will you say it's correct or not?
We won't be telling if you are correct or wrong.
No, I am telling about the Mega Connect.
Yeah, Mega Connect, we will tell you it's right or wrong.
Okay.
So if we get the Mega Connect, in the first attempt itself, we'll get only 40 points, right?
No, you will
Not 60.
get a chance to attempt the next two questions as well.
Okay.
Okay, scores, please.
Can we?
Yeah, scores.
Can we attempt the Mega Connect after every single question? So 3 attempts.
Yeah. 3 attempts at Mega Connect.
Okay, thank you.
So is Team F ready?
Yes.
Vimansa, can we have the next slide? Oh, we were having the scores. My bad. Bhavya, can we have the scores?
Yes, sir. So we have Team B, C, and F at 140. Team E at 100 points. Team A at 90 and D at 80.
Yeah. So this is a direct question for Team F first. Team F, are you ready?
Yes, we are ready.
Okay. Yeah. So a 19-year-old boy came to our outpatient clinic with a history of left knee and hip pain with no visible erythema, warmth, deformity over the past 24 hours. He keeps his limb in the his heart rate is 84, respiratory rate 13, and BP is 124/84. He is conscious, well oriented, and all systemic findings are within normal limits. He had a 1-year history of abdominal pain in the form of on and off shooting pain in the left upper quadrant. The attacks of abdominal pain were not very severe but would last all day, and the severity did not change upon eating or drinking. The patient had undergone examination with all the advanced radiological techniques, including lab, focusing on all possible sources of abdominal pain, but no diagnosis has been reached so far. His mother reports an incident of convulsions last year. While he was diagnosed to have pneumonia with sharp shooting chest pain, which resolved on its own. So, what is the diagnosis, investigation, and treatment? This is the first question of the entire Mega Connect. Team F.
Team F, can we have an answer?
Transient synovitis.
Okay, do you want to go for the Mega Connect?
TV మరియు TV இருங்க ஒரு நிமிஷம்.
What? Can you repeat your Mega Connect?
1 second. Abdominal pain.
Sorry, the Mega Connect is wrong. Can we have the next question for them?
Yeah. A 68-year-old male presented with bilateral neck swelling, intermittent fever, and fatigue of 1 month duration. He also had a history of weight loss of 4 kgs over 1 month. He has a history of intermittent nasal blockage and 1 episode of epistaxis as well. He denied a history of pruritus, chest pain, abdominal pain, and urinary or bowel disturbances. Soon after he started having visual changes and often remained confused with complaint of numbness. On evaluation, his hemogram showed a hemoglobin of 11 gram percent, WBCs 8600, and thrombocyte 1,98,000. He had a nasopharyngeal mass whose biopsy showed neoplastic cells which were positive for CD20, BCL2, CD5, CD22, and kappa. Serum beta 2 microglobulin was also elevated, and the serum protein in total was 9 gram per deciliter. The serum protein electrophoresis had M spike in gamma region. So subsequently, he received 6 cycles of chemotherapy, 3Q weekly, with a combination of cyclophosphamide, vincristine, and prednisolone. So what is your diagnosis?
Guys, your time has started.
It is a plasmacytoma in a multiple myeloma patient. In a patient of multiple myeloma.
And what is your Mega Connect?
Mega Connect is sir poem syndrome சொல்லிட்டுமா? Poem syndrome.
Can we? So no, the Mega Connect is wrong. Can we have the next slide, answer?
Multiple myeloma.
Connect the following images. Your time starts now.
Sir, amyloidosis. என்னது இது?
Can you repeat?
Oh no, I didn't.
Guys, you have 10 seconds left. Can we have an answer? A Connect and a Mega Connect, both.
For this, we will like to go with
Sorry, time
Alzheimer's disease.
Fine. Can we have the final answers? Answer.
And the final connect is all cause amyloidosis.
Okay.
Amyloidosis is the final connect.
So we'll give you marks for the final connect. The connect is amyloidosis. You so will be getting +10, but you won't be getting marks for all the 3 because the answer for all 3 is not correct. Mimansa, can you give the answer slide? So the first question, familial Mediterranean fever. The second question was of Waldenstrom macroglobulinemia. The third connect was actually The final connect is correct. So you'll be getting a +10.
See, the last one is cerebral amyloid angiopathy, right? That can happen even in the setting of Alzheimer's disease. That can lead to lobar hemorrhage.
But we were looking
But
for a specific
we
connect.
wanted, yeah,
Like,
exactly.
I don't know, what were you expecting? Like, fluorobutapir is used for Alzheimer's disease, and not. I'm not sure whether it's for.
But can you explain all the 4 images with Alzheimer?
See, Alzheimer's can lead to this. Okay, cerebral amyloid angiopathy.
Okay, fine. Then.
Okay, so and alpha helix to beta helix, that is the pathophysiology in Alzheimer's, and the second image shows lobar hemorrhage, which is characteristic of this amyloid angiopathies such as Alzheimer's disease, and fluorobutapir F18 injection is used specifically for diagnosis of specifically for Alzheimer's disease.
Fluorobutapir is also used for cerebral amyloid angiopathy. And also, Boston criteria is very much specific for CAA.
Exactly.
Yeah, that is secondary. Like, it cannot differentiate. Like, Boston criteria can, like, it's not telling for primary amyloid angiopathy. Like, primary CA.
Sorry?
क्या बोल रहा है? But see, Boston criteria does not. It tells there is cerebral amyloid angiopathy. It does not tell it's primary or secondary. What is the cause, right?
But it's cerebral amyloid angiopathy, right? Whether it's primary or secondary. We just asked you
When
CAA.
Alzheimer's
Why
can.
are you going into Alzheimer's?
No, like, Alzheimer's also can have the same presentation, right?
Can Alzheimer's make the mega connect as amyloidosis? Will you explain it?
Yeah, like Alzheimer's disease, like, we can have A beta amyloid, right? A beta in this there can be 40 or 42. Anything can be there. In familiar case, there'll be only 40, right? And it's okay, fine, it's okay.
Yeah.
Yeah, so team F will be getting a +10 for their mega connect. Now it's a direct for team A. Team A is ready.
Like, for the mega connect, it's only 10 marks.
Yeah, because you gave it on the 3rd step.
Okay, like, it's not 30 marks total. Okay, fine.
30 is on the 1st step. Can we have a question from Numansa for team A?
Yeah, is team A ready? I just need to confirm.
One doubt, please. For each step, how much time is there?
For each step, we are giving 45 seconds.
Okay.
Except for the connect. For the connect, it's 30 seconds.
Like, in the Waldenstrom's macroglobulinemia, right? You gave there is some spike in gamma region.
Yeah.
That can be seen in any. You didn't tell that it is IgG. Okay, gamma spike is M. That is what is M spike. Gamma spike is M spike. It can be G, A, M, or D, or E. It can be anything. You can see the question.
See, the idea is that we were trying to indicate vessel obstruction. I don't know if you could have made it clearer, because यहाँ पे साफ it's given visual changes, numbness, and everything which one would have
exactly
required.
focusing towards IgG.
Okay.
So can we have the question for team A?
Okay. Team A, your first question. A 41-year-old male presented with the one-day history of high-grade fever, chills, rigors, vomiting, headache, and right periorbital swelling. The day prior to the onset of his symptoms, he had attempted to burst the furuncle on the inner margin of his right nostril. So he had no relevant medical history and was not on any sort of medication. On neuro-ophthalmological examination, there was lid edema, complete ptosis, a proptosis of 6 millimeters, and limitation of all extraocular movements in the right eye. The cornea was normal and pupillary reaction was absent to both direct and consensual light. He had sensory loss of supraorbital area and cheek on the right. What is the diagnosis and investigation of choice in this patient? 45 seconds to you, team A.
Starts now.
Hello?
Yeah.
The diagnosis is orbital cellulitis, and investigation is MRI of orbit and brain.
Can you want to? Do you want to give the Mega Connect?
Proptosis.
Sorry, the Mega Connect is not correct. So we go on to the next question.
Satyam, can you read this out?
Yeah, a 19-year-old female patient reported to the OBGY clinic with altered sensorium and confusion. On taking the history from her mother-in-law, we got to know that the patient took a UPT test 8 weeks ago, which came out to be positive. Unusual menstrual bleeding, which began 3 days ago. She complained of her daughter-in-law to be very careless regarding her nutrition with inadequate intake and repeated vomiting from the past few weeks. She also complained of lower abdominal pain from the past few days, which was more on the right side. Patient's past medical and family history are unremarkable. The mother denied to have known about any allergies, denied drinking alcoholic beverages or smoking in the patient. The patient's temperature was 98°, blood pressure was 88 by 58, heart rate was 123, respiratory rate was 16 beats per minute with a pulse oximetry of 98%. Physical examination revealed sluggishly reactive pupils with papilledema, left-sided facial twitching with ptosis of the eye, bilateral conjugate palsies with nystagmus, and flaccid paralysis of all 4 limbs with bilateral flexor plantar reflexes. Patient's breathing was labored with thread peripheral pulses. Her frontal height was 2 cm below umbilicus. Abdomen was soft and mildly tender on lower quadrants bilaterally. Cervical OS was dilated to approximately 2 cm with some cervical motion tenderness, and the patient was also complained of passing something out of the vagina 1 day ago. What is the diagnosis? The time starts now.
Amniotic fluid embolism.
Would you go for the Mega Connect?
1 second. Causes of all this cause coagulopathy.
Sorry, the Mega Connect is wrong. Can we have the next question? Connect the following images. Guys, your time is already.
Miller-Fisher syndrome.
I'm afraid it's not Miller-Fisher syndrome. Any Mega Connect?
नहीं पता, pass.
Can we have the answers? No answer.
Yeah.
So the first question was a cavernous sinus thrombosis. Investigation choice was MR venopathy. There was a history of the patient bursting a fruncle in his nose. The second case was an H-mole leading to hyperemesis gravidarum causing Wernicke's encephalopathy. The third was Bickerstaff brainstem encephalitis, which was a very close diagnosis for Miller-Fisher, and the Mega Connect was ophthalmoplegia. Can we, so team A gets a +0.
Why can't we orbital cellulitis be the answer? Because the presentation was unilateral, and orbital cellulitis can later cause cavernous sinus thrombosis.
You're not clear.
Hello.
Yeah, Bala, what we had given in this question was first of all there was a lesion of trigeminal nerve also because he had sensory loss, right? Also, third nerve was paralyzed. That is fine. That is common to both.
Okay, fine.
And there was a history of an attempt to burst a furuncle as well.
Okay,
so
fine.
Wo bhi okay.
Yeah. So team A gets a +0. Now we have a question for direct team B. Is team B ready?
Yes.
Yeah. So team B, your question 1 is. Ma'am, answer?
Yeah, just a second.
Connect the following images. You have 30 seconds.
Is it glioblastoma multiforme?
Would you like to have a mega connect? So we go on to the next question. Time is up.
So an 85-year-old female, yeah, an 85-year-old female was referred to our department with a history of slowly enlarging scaly erythematous lesion on the left cheek, which developed over the past 2 years. Completely asymptomatic, it has caused only a cosmetic disturbance. The patient has reported unprotected exposure to the sun 5 to 6 months per year. In the last 30 years, in the last 30 years, she declined previous cutaneous carcinomas of any kind. The attempts to treat it with topical corticosteroids and antimycotic creams did not reveal any results. After careful clinical and dermoscopic examination of the total skin, no other suspected lesions were noticed. Dermatological status showed scaly, slightly elevated erythematous plaque with dimension 9 into 7.5 centimeters and well demarcated borders from the surrounding healthy skin. Histopath examination revealed parakeratosis in stratum corneum, the gnomic cells in the superficial layers of epidermis, as shown in the histopath slide below. The individual dyskeratotic cells and increased mitotic figures were also evident in the spinous layer. So, what is the diagnosis and treatment in this case? Please refer to the histopath image. It's very much characteristic.
Guys, 10 seconds left. Can we have a diagnosis and a mega connect?
Bhavan's disease.
And what's the mega connect? So I guess no mega connect. Can we move to the next? So we are moving to the next question. Question 3.
Okay.
Part C. They have not given the mega. They have given a diagnosis. Move to the next question.
Yeah. Okay, so part C. A 52-year-old male presented to the clinic with the complaints of breathlessness, fatigue, and cough with sputum production. These symptoms appeared 3 weeks ago and the onset was insidious. On general examination, the patient had fever, lymphadenopathy, pallor, and also hepatosplenomegaly. The severity of cough had increased in the past 1 week. There was no history of hemoptysis and lung crackles were heard on auscultation. Sputum tests were ordered, which revealed acid-fast bacilli in the sputum smear. The hematological investigations revealed the following findings. Hemoglobin was 7.2 grams per deciliter. WBCs was 2120 and platelets were 52,000. Immunophenotyping revealed CD19 positive, CD25 positive, and CD103 positive cells. What is your diagnosis?
Guys, you have 10 seconds left. Can we have a diagnosis and an MCI? Yeah.
Is it MAC infection after Harris leukemia?
And the Mega Connect?
Okay, and what's the Mega Connect?
Leukemia, like that.
Sorry, it's not leukemia. So can we have the answer, Mamansa?
Yeah.
So the first connect was oligodendroglioma. The second was Bowen disease. You get a plus 10 for Bowen disease. And the third was hairy cell leukemia. And the Mega Connect was fried egg appearance seen in all these three conditions. So team B gets a plus 10. Can we move to?
I said Harris leukemia, right?
Yeah, you'll get a plus 10 and a plus 10. So you get a plus 20. Yeah.
You get a plus 20 for diagnosis and you get a 0 for the Mega Connect. So plus 20 to team B. Okay, note that. Can we move on to the next question? That is for direct for team C.
Team C ready?
Yes, we can move on.
Yeah.
Okay.
So the first question for you is, a 50-year-old male with no case of diabetes mellitus, hypertension, and end-stage renal disease presented to the emergency room with pain in the left ear discharge, and headache for the past 8 months. The ear pain increased with left facial weakness for the past 1 week. No other relevant significant history was documented. Granulation tissue in the left ear canal with mucoid discharge and edematous canal were evident on ear examination. A diagnosis was made. Intravenous fluoroquinolone was started, but he didn't approve. So left canal wall down mastorectomy and debridement of the surrounding tissue were performed. Surprisingly, yellowish material with thick fibrous cord was found in mastoid cavity, extended from the posterior canal wall to the sigmoid plate. Histopathology came as filamentous branching organism. What is your diagnosis and what is so special about this case? Your time has started. Guys, you have 10 seconds left. So can I have a diagnosis now?
So it is, I think, treatment was with IV fluoroquinolones, which treated the pseudomonas part, but there is also an coexisting aspergillus infection. So that's what, because of prolonged immunosuppression, both can coexist.
So that's one point. What is the diagnosis?
To keep.
Sorry, we cannot give you more time. Do you want to try for the Mega Connect?
Immunosuppressed state complication.
No, we will. The Mega Connect is not wrong. We will move to the next question. Answer, can we have the next slide?
Yeah, I just did it.
Guys, you have 10 seconds. Can I have the connect now? Team C. Team C.
No, you can move ahead.
Okay, we'll go for the part C. A 1-year-old male patient who was born full-term at 38 weeks with intrauterine growth, retardation, came to hospital with abnormal facial expression. The parents were unrelated and young and healthy at the time of conception. The labor history was uneventful, with the usual labor induction and normal progression. No drug was consumed routinely by the mother during her pregnancy. The infant was brought to the pediatrician with the complaints of a restricted mouth opening, restricted gaze, and an expressionless face. There was incomplete closure of the left eyelids during sleep and drooling of saliva. Generalized hypotonia was seen. Muscle tone was being more decreased around the shoulders than in lower extremities. No clonus was elicited. Limb malformations were not obvious, although minor syndactyly was present. His right upper limb appeared to be hypoplastic with fourth partial syndactyly. The eye movements were restricted, especially when the child tried to look on the ipsilateral side. Rest all eye movements were normal. Can I have the diagnosis? The time starts now. 10 seconds left. Can we have an answer now? And the Mega Connect as well.
Is it Mobius syndrome?
And what's the Mega Connect?
Maybe.
I'm afraid we are running out of...
Facial nerve palsy.
Okay, we'll give you plus 20. The last diagnosis is correct, and the Mega Connect is also right. It's the causes of facial seventh nerve palsy. So team C gets a plus 20. Mimanta, can we have the answers? So the first question was a malignant otitis externa, which you were right was caused by a fungus. The second diagnosis was Lyme's disease. There was a target-like lesion. Justin Bieber is known to have Lyme's disease, and there was atrophic as well. And the last question was of and the back pain showed meningoradiculitis. And the final question was in obviously Mobius, and you have got the Mega Connect right. So we give plus 20 to team C. Now it's the direct for team D. Is team D ready?
So how do we get a plus 20? Like it is we get A and C correct, and the Mega Connect.
Correct. You just said the fungus, which was an additional point. You didn't have.
No, because we told it is first Pseudomonas and both can coexist, right? It's
both can coexist, but you have to. But we wanted a diagnosis. The question
that was.
But you didn't ask the diagnosis. You said that.
You said what was special about the case.
Can we have the question again? Himanshu, what is your diagnosis and what is so special about the case?
We told no Pseudomonas otitis externa. We told.
You said only Pseudomonas. You didn't add the otitis externa part.
It was evident, right? Because in a diabetic, this two only can cause.
Filamentous branching organism.
I agree with that, but you didn't say Pseudomonas otitis externa. You said Pseudomonas with a fungus. We'll give you plus 5 for that, but not the whole plus 10.
Okay.
Fine, because we had subparts. So can we have plus 25 for team B, team C?
So we get 10, 10 and 5, right?
Yeah.
Okay.
Yeah.
Can we have the next question for team D?
Team D, are you ready?
Ready.
Mimantha, take over.
Yeah, sure. An 11-month-old male infant born of a first-degree consequently of erythematous rash over the central face on exposure to sunlight, followed by peeling of skin since 3rd week of life. Patient had a history of failure to thrive since 5 months of age and delayed milestones. Physical examination revealed a proportionately short-statured infant, having both weight and height lying below the 3rd percentile for age, head circumference below the 1st percentile. There is also a marked loss of subcutaneous fat, resulting in a wizened appearance with typical bird-headed facies, prominent Mickey Mouse ears, sparse dry hair, and a thin nose as well. Ocular examination showed hazy cornea, stromal opacities, optic disc pallor, and subpolar cataract. CNS examination revealed low intelligence with normal motor and sensory functions. Systemic examination revealed hepatosplenomegaly. Cranial CT showed calcifications in bilateral cerebral hemispheres, white matter, and basal ganglia with diffuse cerebral atrophy. What is your diagnosis?
The time starts now.
Diagnosis is probably Bloom syndrome.
And the Mega Connect?
DNA repair defects.
Can we have the next question? The Mega Connect is not right.
Yeah, so a 1-year-old boy presented with motor retardation, short tubular bones of hand, feet, and ichthyosis-like features. Pregnancy and delivery were uncomplicated, although there was a history of second-degree consanguinity between the parents. By the age of 2.5 years, the child had it was pale and had reduced night vision as well. On physical examination, the skin was pale, there was hepatomegaly, and a 2/6 systolic murmur with strabismus, hyperopia, and bilateral astigmatism. There was generalized hypotonia with stereotypic movements such as shaking and bending forward. Deep tendon reflexes were decreased in upper and were normal in the lower extremities. Lab findings showed a decreased hemoglobin of 4.6 grams per deciliter and an elevated ammonium level of 400 milligrams per deciliter. Concomitant cranial MR was performed and it revealed bilateral increased signal intensity on T2 weighted images in the substantia nigra, subthalamic nucleus, and globus pallidus. The fatty acid levels were also deranged in this patient. Over the next 5 years, the child has progressive mental and motor retardation. What is the diagnosis? So your time starts now.
So you have 10 seconds left.
Okay, diagnosis is, I think, Refsum disease.
Answer the Mega Connect.
Paroxysmal disorders.
The Mega Connect is wrong. Can we move on to the next question? Connect the following images. So can we have the connect now?
Diagnosis, this one is probably A beta lipoproteinemia.
Run the Mega Connect.
Just a second. How much time do we have for Mega Connect?
Sir, actually you have to do it right now because it was already adding up.
Okay, connect is mega connect, probably night blindness.
You were, sir, close. So we'll give you plus 20 for 2 correct diagnosis. Hello.
Hello. Sir, can you make your answer better? You're very close.
Which one? The mega connect.
Yeah.
Just a second. Just a second. Mega connect is retinitis pigmentosa.
Yes, it's correct. So we'll give you plus 30. So the first disease question was of cocaine syndrome. The second was Refsum, answered correctly. The third was A beta, answered correctly. And the mega connect is retinitis pigmentosa. So they get a plus 30. Team D. The next question is to Team E direct, the last question for the quiz. Can we have the question answer? Is Team E ready?
Yes, we are ready.
Yeah. So the first question for you is, connect the following images. You have 30 seconds. Guys, you have just 5 seconds left. Can Team E?
Rheumatic heart disease.
And the mega connect? You are not clear. What's the mega connect?
One second. All molecular mimicry disease.
The mega connect is not is wrong. Can we have the next question? A 16-year-old female presents to the family physician with lethargy, tiredness, and increased fatigue. The physician examines her and finds out pale skin and suspects iron deficiency anemia. The patient's blood sample reveals microcytic hypochromic anemia and oral iron tablets are prescribed. After 3 months of medication, the patient's blood indices come out to be normal, but she still reports fatigue and tiredness and shortness of breath. The physician asks for her menstrual history, to which the patient replies that it's normal according to her family. She has heavy periods lasting 7 to 8 days, even sometimes up to 10 days, and has to use double pads to secure complete absorption. Her mom counseled her when she started having her periods, stating that heavy periods are their family thing from the mother's side. The physician further inquires about the menses, which are reported to be including large chunks of semi-solid blood greater than 1 inch in diameter. Coagulation profile is the prothrombin time is 11 seconds. The activated plasma prothrombin time is 60 seconds. The thrombin time is 10 seconds. What is the most probable diagnosis? The time starts now. Guys, 10 seconds are left. Can we have an answer?
Non-Willerson disease.
And what's the mega connect?
Sir.
Can you be more clear with the mega connect?
One second. Error.
Teamy, can you be more clear with the mega connect?
One second. And we are going for next question.
Yeah, next question, please answer. The patient is an 85-year-old man who presented with constipation, left-sided abdominal pain, and weight loss all 2 weeks duration. There was no anorexia, abdominal swelling, diarrhea, or hematogesia. A physical examination was unremarkable. No abnormality was detected on digital rectal examination. Abdominal pelvic ultrasonography showed normal findings. Colonoscopy revealed the following findings: no other abnormalities seen in the bowel mucosa. No ulcers or mass lesion was seen. The UG tract endoscopy done was normal. What's your diagnosis? The time starts now. Guys, you have 10 seconds.
Is it GA angiodysplasia?
And the Mega Connect?
Is factor 8.
So we'll be giving you plus 20 for the second and the third diagnosis, getting it right. It is von Willebrand disease, and it is.
Is it Haiti syndrome? Actually, the question.
You can't get the second guess exactly because you mentioned it.
No, it is angiodysplasia of colon, right? It involves.
Yeah, it's angiodysplasia, but the Mega Connect was Haiti syndrome. So you'll be get plus 20 for angiodysplasia and for von Willebrand disease.
Okay.
And the first question was of aortic stenosis. Mamansa, can we have the first question? The connect. So this one, this one is the ejection click which is present. The last one was late and weak, that is parvus et tardus pulse seen. This is a fish mouth appearance which is seen in bicuspid aortic valve predisposing to aortic stenosis. This was the concentric hypertrophy seen, and the first sign is the Gallowardin sign. That is an murmur is seen at the apex, which is not related to the axilla differentiated from MR. So the Mega syndrome, you get a plus 20.
Can you tell us the image at the top right corner, that black image? What it represents?
So that's a click. That's a click for the ejection click seen in AS.
This is a very good connect, by the way. The entire Mega Connect.
So this was Haiti syndrome. With this, we come to the quiz, and we'll have the scores and the results ready within a few minutes. Thank you.
By the way, we have one round left. Team E.
Yeah, we have. I have that question. Just give me a couple of minutes. I am opening that question. I have the question ready. So every team get ready. That's a pounce and a bounce round that was left, and it's a direct to team E. Can I have my screen in sharing? Avya? So are you guys ready for the question? Is everything ready?
Yes, we are ready.
Yeah, it's direct for team E, and there's a pounce and bounce available as well. So the question goes as follows. Oh, just a minute. A 6-year-old boy was born to first-degree healthy consanguineous Tunisian parents. His family history was unremarkable. In particular, no sibling or other relative affected in the family. Pregnancy and delivery were uneventful. His past medical history was significant for intractable epileptic attacks starting at the age of 6 months. He presented with psychomotor delay. Work acquired at 2 years, language 4 years.
ये वाला हो गया है.
Hello, this was already asked, right?
Just a minute. I must have opened the wrong one. Just a minute. Guys, give us just 5 minutes. We are making the We are making the question in the presentation. Just a couple of minutes. Really sorry for the delay, guys. Is everyone ready? We are ready with the question. Call your partners if they are not here. So is everyone ready? It's a pounce and bounce round, direct for team E. I'm sharing the question now. So the question goes, a 39-year-old male presents with fever, myalgia, shortness of breath, diarrhea due to concerns of COVID. On the history presenting illness of the patient says, 5 days ago, loose non-bloody stools. 2 days later, fever, chills, cough with blood-streaked sputum, and progressive shortness of breath. The chest pain is sudden onset, sharp stabbing in nature on the right lower chest. The patient has a prior history of asthma for which he took nebulization at the community hospital. On examination, the patient was conscious but confused. He was running a temperature of 103 degree Fahrenheit. The respiratory rate of the patient was 28. The heart rate was 98. The BP by 75. The SpO2 was 90%, which improved to 98% in 4 liter. The patient had crackles at right lower lobe, V's present, serious regular rhythm, no murmurs, rubs, gallops. On abdomen, the examination was soft, tender, non-distended. The lab of the patient were WBC was 15,000, HB was 9.3, platelet was 269,000, potassium was 4.9, sodium was 132, the glucose was 126, procalcitonin was 3.38, D-dimer levels were normal, SARS-CoV-2 nasopharyngeal swab was negative, gram staining revealed numerous neutrophils, but no organisms. Give 2 highly specific tests for this condition and treatment. It's a pounce round. Your pounce window starts now.
Can you please go back to the previous slide?
Yeah. The pounce window is open for another 5 seconds. The pounce window closes in 3, 2, 1. So it's a direct for team E. Can we have the answer, team E? Team C, the pounce window is already closed. Team E, can we have an answer? Team E.
Pass it.
Team F, can we have an answer?
I think it is Legionnaires disease, and 2 highly specific tests are urinary antigen detection test we can use, and a culture in we can do culture also. Culture in Palcam medium we can do, and treatment is mainly macrolides, azithromycin. Hello.
Yeah, can you
Hello,
repeat?
can you hear me?
The second test, which one you are, the highly specific second test which you're getting?
I cannot, what are you telling? Hello? First highly specific test is urinary antigen detection testing, which is nearly
The
99%
first one
specific.
you have said is urinary antigen. What is the next test you have said?
See, I will do culture in BCYA agar. Buffered charcoal yeast extract agar.
Okay, fine. We'll give you marks for that.
And the treatment is macrolides, azithromycin,
So,
or you can use even respiratory fluoroquinolones also.
Yeah, so we are giving plus 20 to team F for the direct answer.
Yes.
The answer itself is Legionella, and the 2 specific tests are Legionella urinary antigen and direct fluorescent antibody staining of the sputum or cultured transtracheal aspirates of the patient. So guys, we'll be compiling the results in a while. Thank you for being so patient and so long with us. I hope you all had an amazing quiz. Sorry for all the problems we had, network issues or the question issues. It was the first time for everyone having an online quiz. We have done many offline quizzes, but this was a good experience for us as well and a learning opportunity as well. Hope this was for you as well. Thank you, guys. Wait for
The questions were very good. The quiz was also nice. So thanks to you for making such good questions. Thank you.
Thank you.
हाँ भाई मजा आ गया यार कब से जा रहे थे तुम्हारी क्विज बहुत तगड़ी क्विज थी मजा आ गया
Thank you. So I would also like to tell you the each and every person who was behind this quiz. So from final year, we had Mimansa Jindal, I myself Satyam Gupta, and we have Shubham Arora from final year. From third year, we had Anjali Jangra, we had Anukriti Kaushik, and also we had Sagar Gumbar. From the second years, we had Akshay Gill, we had Shubhadeep, and we had Sukrit Singhal, and we also had Bhavya Pava, who organized the event with the AMSA and helped us make the quiz as well, and handled the technical part as well, along with Yashdeep. So this was a team effort by everyone, as each and every one of us, and I would really like to appreciate the second years and the third years. They helped a lot in us in making this integrated quiz possible.
Also, we had Chetna Dengri ma'am, whose constant support was us. Whose constant support was
Actually, we had dropped the idea of making a
with
quiz.
us
It was
the
Sheta ma'am
entire
who
time.
forced us to make the
And
quiz.
Amir sir, yeah,
And
exactly.
we'll have Amir sir.
Chetna ma'am, Yash sir, thank you, both of you. Yeah, so we have Amir sir, who is the faculty advisor of ILLUMINOUS, the Mid-Quiz Society of UCMS. He has always been supporting us. It's been a 3-year journey ever since ILLUMINOUS started. And ever since then, he's been with us, be it a live event, be it an online event, he's always been there. So thank you, Amir sir.
And even all the participants, they were so good.
Yeah, surely
I
the
hope he's there on the chat.
We had, I guess, around 300 entries in the prelims. Out of them, few were eliminated due to the time issue. And out of those, selecting these 6 teams was a very tough competition. We almost went into a tiebreaker for the teams as well. So kudos to all the participants who took 4 hours with us, especially the interns. So we'll be back with the results and the scores in a while.
Yeah, meanwhile, can we have introduction of all the participants, their colleges and their years? Starting from Team A.
I am Arman Seth, final year student from Maulana Azad Medical College.
तुम्हें कौन नहीं जानता भाई?
Answer क्या? Dattatre Shukla, final year student, Maulana Azad Medical College.
अर्श सर कुछ कह रहे थे आप?
I'm just saying hi to everyone. That's all.
हर सर को कोविड हो गया है.
हाँ भाई ना.
Can we have Team B introduce themselves?
Myself, Rakesh, final year student from IGMC Pondicherry. My teammate is Vishwata from second year IGMC Pondicherry.
Can we have Team C?
So I am Anirban Dev from JIPMER final year.
Yeah, I am Swami Jati Raha, JIPMER Pondicherry final year.
I am Ayush from MAMSI intern.
I am Harshu Preti, an intern in MAMSI.
I am Pranav Sakti Saravan, ESIC second year.
I am Dakshin, a final year student from ESIC Chennai.
This is John Emmanuel, intern from JIPMER.
This is Vidyasagar, final year from JIPMER.
So we had an interaction. We had a all India quiz for the first time. Usually we used to have colleges from MAMSI, VUMC, LHMC, UCMS teams at our offline quizzes. It was a really nice experience interacting with you all. Bhavya, is the results ready?
I just need a minute.
Yeah, sure. Also, the Mansa inform Amir sir about the prizes and the result as well.
Yeah, on it.
So I'm still confused about the last one. Can you just repeat the last में किसको start करना?
Bhavya, in the last round, no one got the pounds right or wrong because so the last round was 20 for team F.
Okay, that's it, right?
Yeah.
Okay.
Guys, so we have Amir sir with us. Let's just wait for 5 more minutes. I guess Mrinalini ma'am and Dheeraj sir will join us shortly. Okay, so Amir sir, Mrinalini ma'am, and Dheeraj sir have joined us. Can we have the results, Bhavya?
Oh yes, ma'am. I have shared it with Amir sir. I'd love if he announces them. Maybe.
Okay. Yeah, Amir sir will do that. You forwarded them to him, right?
Yes, ma'am.
Thank you. Just got the results. What an exciting event it has been. So I will just announce. Is Dr. Dheeraj there?
Yes, Dr. Amir, I am there. Please continue.
आमिर सर आपका स्क्रीन ऑफ है.
I am. Yes, my screen is off. Yes, I'll be putting on my screen. There is some problem with this internet connection. Let me see. When we don't want to wait, we have to wait. I will forward the Bhavya. Can you please forward the winners list to Dr. Dheeraj and Dr. Mridalini also? So I will just announce so the teams were this team A, Bala and Arman from MAMSI. Team B, Rakesh and Vishwat from IGMC. Team C, Anirban and Soumya from Jipmar. Team D, Harsh and Ayush from MAMSI. Team E, Pranav and Dakshin, ESIC. And Team F, John and Vidya Sagar from Jipmar. So I will announce the second runner-up, and first runner-up will be announced by Dr. Mridalini, and the winner will be announced by Dr. Dheeraj. Is it okay? Hello?
Amir,
Am
you
I
can
audible?
do. Yeah, you are audible.
I'm audible? Okay.
Yes.
So I will be announcing the second runner-up. First runner-up will be announced by Dr. Mridalini, and the winner will be announced by Dr. Dheeraj. So the second runner-up is Rakesh and Vishwat from IGMC. Many congratulations to the winners, and congratulations to all for participating in this very interesting and giving a tough competition and coming up to this level. So congratulations from all of us.
अभी करना है सारी काम.
So first runner-up will be announced by Dr. Mridalini. Dr. Mridalini, you have the results with you?
Yeah, I've got it. The first runner-up is Team C, Anirban and Soumya from Jipmar. Congratulations, Team Jipmar.
I
You
will
deserved
clap.
it.
Thank you, ma'am.
Many congratulations.
Thank
Well
you,
done.
ma'am.
And at last, the
And the
winner
winner team will be
is Team F, John and Vidyasagar from Jipmer again. So many congratulations, Jipmer. And all the teams who participated as well as who won first three positions.
And of course, everyone and the organizers.
Thank you, ma'am.
Organizers did a wonderful job. Very good questions.
Thank you,
Whatever I
ma'am.
heard, it was really good. Very good.
मैं तो quiz में tough question थे मेरे हिसाब से। आजकल जो है students इतने tough question कर लेते हैं, that is really amazing.
Yeah. That shows that how good they are in understanding the subject, because they're able to pick the nitty-gritties of the questions, and they're not very straightforward. They are
Really.
more of thinking kinds and analytical kinds. Really
Yeah,
good.
and case-based learning they are doing. The
Yes.
photograph and all those cases developing.
Yeah.
Amazing.
Really good. Very good. Congratulations.
Congratulations to all.
And of course,
Bhavya, Chetna, Shubham, मीमांसा और कौन सा ये अभी सत्यम था, क्या नाम है उसका?
Yes, sir. Satyam.
Satyam.
हाँ सत्यम, तो और सुकृत सिंगल भी है शायद। हाँ, तो सबको, और अगर मैं किसी का नाम मिस कर रहा हूँ, सॉरी। Congratulations to all and thank you very much for organizing this, and
Actually,
thanks to
Amir,
AMSA and MARROW.
Actually, Amir, we have seen them growing from first year onwards. No? It's really very nice feeling to see them evolve as such brilliant future doctors. Really very nice. Very proud of all of you. And of course, the winners, they are really good.
Ma'am, can I ask everybody to please turn on their videos? We just want to take a screenshot as a memento of this quiz.
Okay.
Participants, please switch on your videos. Team, you too, please.
Shubham, Shubhadeep.
बता देना कब स्माइल करना स्क्रीनशॉट में, जो फोटो कब आएगी।
Sure, sir. Shubham, please turn on your video.
तो वरना पता
Akshay,
लगे जो
Sukrit.
स्क्रीनशॉट खींच रहा है वही मुस्कुरा रहा है।
Bhavya, please switch on your video. Okay, so Bhavya has some connectivity issues. I think rest everybody is fine. Sukrit, Shubham, Akshay.
I guess Shubham is busy. He's not picking up his phone. तो हम ऐसे ही ले लेते हैं. Amansa, are we done?
Yeah, I think we are done, right, Bhavya?
Yeah. बाकी के हम Photoshop कर देंगे.
बहुत। Okay, thank you everyone.
Thank you, sir. Thank you everyone.
All. Bye. Bye. Good night. Enjoy the Sunday and enjoy winners and participants. Everybody have a great
Thank you,
weekend.
Amir sir, Dheeraj sir, and Mrinalini ma'am for sparing your time with us. Thank you, participants, and congratulations to all.
लीव करो जल्दी दो, अभी एक और Zoom मीटिंग है.